pulmonary trunk. So practical points we should consider during the CT angiogram. In my practice, usually if the patient have a CTIF findings, or we know where we should look for CTIF, we should ask for a little bit delays, not like a normal CTPA, we done it for every patient. We should consider delayed a little bit images, about 10 seconds, because the resistance of the hypertension can give you slow flow for the pulmonary tree. That's why we should pay attention. If the patient have a chronic filling defects, we said, please, talking to the radiologist or the technologist to say, make it a little bit delayed to assist the distal vessels to not mix it with a slow flow artifact, a smoking artifact, or not complete opacification of the pulmonary trunk. And we should do the bolus tracking for the pulmonary trunk that's a technical part for the CT angiogram, how to perform. That's more articles if you would like to see any more articles about or references for the pulmonary hypertension and imaging. And I think we conclude here our workshop. Any question regarding how to go through the CT scan or any difficulties you face it during your practice from the radiological point?
We have mics on the, yes, Doctor.
Thank you very much for the informative lecture. Just want to know if you can highlight about, are there cases where for CTIF we can find a discrepancy between the CTPA and VQ, or do one before the other and find a positive VQ and a negative CTPA, or vice versa?
Okay, that's an interesting question, actually. Yes. So we have in our hospital some MDT meeting about the pulmonary hypertension and CT findings. I face one case like this, that usually the screening is the VQ scan to see the distal vessels, the filling defects. Usually the VQ scan is more for screening, more sensitive for diagnosis. The CTPE, usually we have struggling with the technical part. So I will be more confident to look for a VQ scan. If it's positive, that's making me more sure it's a CTIF finding, especially the distal disease. So the VQ scan, you can see the distal disease. For the pulmonary CT angiogram, the problem is to know the ideal for the CT to look for the anatomy or where's the filling defects. That's the ideal, or that's the purpose for the CT scan. In my practice, we have case, I think one case, that's a CTPE there is some filling defect, but the VQ scan was normal. But I think that's one case which wasn't clear and for us as well. So we end up with a pulmonary angiogram and we do some further investigation. But in a practice, usually the VQ scan give you more positive finding than the CTP, especially for the distal disease. To differentiate or how to overcome this, in our institute we do the full imaging part, VQ scan and CTPE, and if we need cath, we do the cath. So it's combined process.
Thank you for your presentation. Just I want to ask about what are the more information given by the SPA or digital subtraction pulmonary angiography compared to CTPE regarding CTIF? What are the adding information given by the SPA compared to CTPA?
Okay, you mean the pulmonary angiogram, the cath? Sorry, I didn't get the question. What's the difference between?
Digital subtraction pulmonary angiography compared to computed tomography pulmonary angiography in CTIF.
Okay, so that's related to the cath part. For the CT angiogram, they find recent studies, they are equal in imaging because we should look for the major or the proximal disease. If they found some articles, the CT angiogram, it's similar to the DS or the pulmonary angiogram by cath or catheterization. It's similar to almost the same percentage, 98 or 97 sensitivity and specificity. But for sure, the gold standard is the pulmonary cath to see where is the defects and how it goes, which vessels are non-opacified by cath. For the CT, it has a good diagnostic factor. and the filling defect, usually the proximal disease, you can appreciate it in the CT. The iodine subtraction for the CT, not the cath, the iodine subtraction, it helps a lot for picking up the findings, but usually in our institute, we used to have it, but it takes time to process it, and some software you acquired to do these dual energies CT scan. But it's just only an active tool or an additional tool to just make it more colorful or more confirmative tool to, you can be more confident to call it as a CTPA positive.
Okay, any more questions? So we have 3 more minutes. I'd like to give the last question. Thank you for a great presentation.
Thank you.
So do we have any statistics about the predictability or the high predictive value of the CT findings, how strongly they correlate with echo and right heart cath findings, such as pulmonary artery dilation? How likelihood a patient with pulmonary artery dilation will have pulmonary hypertension on right heart cath?
Yeah, that's a nice question. Usually by imaging, we didn't diagnose pulmonary hypertension by CT scan because...
yeah, sure. It's just I'm asking how likelihood it will happen.
So that's why I mentioned there are some findings give you the suggestive of the pulmonary hypertension because it's accumulative findings including the dilated IVC, the reflux, the enlargement of the pulmonary trunk. We didn't use one tool to evaluate, but for the pulmonary hypertension, the CT is not a tool for diagnosis. How close to it? Usually I know some statistic related to the CTIF findings. How accurate to the CT or the cath findings? They are almost similar. That's why now you can see every CTIF department, they ask for a CTPA to obtain, to see where's exactly the findings. Probably we should go to the multimodality team. You can see here in the table, you can appreciate the CT, how with the strength bond. It's about the anatomy. That's in the 2 column here, that's CT, and the pulmonary angiogram. The echo, we didn't have it over here, but I didn't have information about the statistic between the echo and the CTPA or CT angiogram.
That will be interesting to look for. Thank you for your presentation. Thank you for the audience for attending and listening. And we have another workshop coming. Thank you.
شكرا دكتورة.
Okay, ladies and gentlemen, welcome back to already the next session, which is also a pre-conference workshop. We are very grateful that we put the topic of right heart catheterization here and highlight the importance of invasive measurement of hemodynamics. And it's a pleasure and honor to introduce Abdullah Al-Qudair, who will give us a lecture, but also will challenges us a little bit with questions, and we can also discuss in between. We just thought that might be a good way to do this. So we're very grateful, Abdullah. Right heart catheterization, state-of-the-art measurements.
Thanks, Stefan. Good afternoon, ladies and gentlemen. So we'll get started with this workshop. So there's nothing better to start with than history. So the history of catheterization in general started in 1929, and it's a very interesting story. So Dr. Werner Forsman introduced a catheter into his own right arm. Sounds interesting, right? So basically, the story started when he asked a colleague of him to place a large needle into his antecubital vein, and that's an interesting thing to do because right now, this is the preferred access for our right heart cath is to do it brachial. So his friend inserted a urethral catheter and advanced it all the way until they reached 35 centimeters. And then at that point, his colleague was not very comfortable of doing further advancement, and he resisted and thought it was too dangerous that he wanted to terminate the experience. So Dr. Forsman himself, a week later, he decided to do it himself, and he placed a sheath in his antecubital vein and advanced the catheter this time all the way to 65 centimeters. And then he ran upstairs to where radiology was at that time in his hospital, and he captured this picture, which constituted the first angiogram, basically, although there was no contrast, but the first catheterization procedure. And you can see, I'm not sure if it projects very well here, but you can see the tip of this catheter all the way in his right atrium. He describes nicely the feeling that he had during this experiment. He said, during passage of the catheter, I was aware only of a slight feeling of warmth from the sliding along the vein wall, similar to the feeling one notices during intravenous injection of calcium chloride. I'm not sure how that feeling is. So basically, this was the first ever right heart catheterization. So I'm an interventional cardiologist, and I know for sure that sometimes we get these cases in a busy cath lab day, and my friend, interventional cardiologist, they say, okay, let's do this case. It's just a right heart cath. So that's a common saying. I'm not sure if it's only in my cath lab or in other cath labs too, because they see it as a quick procedure that needs like that doesn't need much time or preparation. But it's not. It's not just a right heart cath, because the problem with right heart cath, if you don't do it very well, then you will have more questions than answers. So you really need to pay a meticulous attention to all the details in order to obtain a clinically useful information. So in general, if we're doing right heart cath for the assessment of pulmonary hypertension, it should be done in a stable situation in non-acute clinical conditions for differential diagnosis of PH. For example, you don't want to do it in someone who's volume overloaded. You don't want to do it in someone who's hypoxemic on oxygen. And ideally, it should be done after the assessment with all of the other modalities of pulmonary hypertension has been completed. So it should be the last part of the diagnostic workup. In general, the patient should be eovolemic, and we should avoid sedation as much as possible. Okay. There are not much contraindication to right heart cath, but one of the important things that we have to pay attention to is the presence of left bundle branch block. Why? Because a lot of times when we go and manipulate inside the around the tricuspid valve, we accidentally knock off the right bundle. And if you have a patient with pre-existing left bundle, guess what's going to happen? you'll end up with a complete heart block. So lift bundle is not a contraindication, but if you see it on the ECG, then you should be prepared for a temporary pacing in case you have an accidental complete heart block. Same thing goes with if you have a recent pacemaker. Again, that's not a contraindication, but if you have one, you should be probably very careful not to dislodge the newly implanted pacemaker leads. You should always inspect the pressure tubes and ensure that they are short as much as possible, they're tightly secured, they're free of air, kinks, or blood clots, and full of normal saline in order to obtain a meaningful pressure reading. And in general, you should be able to print up or store the ECG and pressure tracings because, you know, we see right heart cath data all over, but without really seeing the tracings, we cannot really ensure that what's written as an interpretation is reflective of the true pressure tracing. Is there any contraindications? Yes, very little, very few. So one is if you have right-sided endocarditis, of course you don't want to go and dislodge the vegetation into the lung. Same thing goes for if you have a right chamber, right intracardiac mass, either in the RA or RV. And if the right of the tricuspid pulmonary valve has a mechanical valve, then that's also a contraindication because sometimes the catheter introduction can lead to a stuck valve. By the way, it's not very common to have mechanical valves on the right side of the heart, but they do sometimes. Okay, so before we get started, a very important concept is the pressure transducer leveling and zeroing. So what do we mean by that? So in right heart catheterization, we're interested in measuring multiple different pressures, but the one pressure that we are interested in the most is the left atrial pressure. So because of that, we want to have the left atrium as the area where our leveling is going to be. So how do we level our transducer at the point of the left atrium? There have been common or multiple different ways of where to level the transducers, but the most commonly and agreed upon way is that we look at the mid-thoracic level. So how do we do that? Because the mid-thoracic level is the point where actually, in most people, represent where the middle of the left atrium is. So how do we do that? So this is an example of a hemodynamic monitoring system. And you can see there is a line that says locate at mid-heart level. So that line should be lined at the mid-thoracic level of the patient. So we get a ruler and measure where the mid-thoracic level at the patient level is, and then we make sure that this correlates with this line here. So that's what's considered leveling. Then zeroing basically is opening the air opening the pressure system to air so you can basically have a baseline at that level. So the most common catheter that we use is a Swan-Ganz catheter. So basically it's a multiple lumen catheter. It has the ability to measure pressure at the distal port. It has the ability to inject contrast or saline at the proximal port. And there is also a thermostat or thermistor that can help us with the thermodilution. And then the final port here is the balloon tip. So the balloon is basically used so we can push the catheter in an atraumatic way, and it also helps float the catheter so it goes to the pulmonary artery. This is Mr. Swan and Ganz. They came up with this invention back in the 1970s. What about the access? So similar to the first catheterization ever, the most, or in my opinion, the best access for any right heart cath procedure is the brachial vein access. But we can also use internal jugular and femoral access. So why do I think the brachial vein is the best one to use? Multiple reasons. One is it's easy for the patient, easy for the operator as well. Hemostasis is rapid, simple, and cheap. The patient can ambulate right after the procedure without the need for long bed rest. And the risk is basically very minimal. The only probably significant risk is if you have an inadvertent puncture of the nearby vessels or nerves. So this is the anatomy of the venous system. And you can see here in the median cubital vein, it goes from the cephalic to the basilic vein. We like the one that is going to the basilic vein because it has more smoother course of passage, especially up in the subclavian junction, as opposed to the more lateral one, which is the cephalic, which has a more of a sharp deflection that can make the advancement of the catheter a little bit difficult when you reach the subclavian junction. So how do we do this? We usually ask our nurses to place an IV in the holding area. Usually 20 gauge is enough, and we ask them to choose the vein that is pointing more towards the medial side. If they cannot do that, or the patient has difficult access, then we can do that in the cath lab using an ultrasound and a tourniquet to engorge the veins. And if you get this one, then it's easy exchange. So you basically put a small wire inside this, remove the needle, the angiocath, and then put a regular sheath. Now, sometimes we have resistance when we advance the catheters up from the antecubital vein. So if that's the case, then you can visualize this underfloor. You can deflate the balloon, pull back, inflate again, and push again. You can ask the patient to take a deep breath or move the arm one way or another. Sometimes injecting contrast can help you navigate through the different parts of the venous anatomy. A lot of the time, advancing a wire can help. Sometimes nitroglycerin can help as well. And if all of that fails, then there are multiple roads that leads to Rome. So you can go for femoral or IJ. But it's very rare that we have resistance for a brachial access. Now, when we measure pressures, we have multiple different chambers in the heart that we are interested in. So in the RA, PA, and Wedge, we measure the phasic and mean pressures. And in the RV, we only get phasic. And usually we like to measure the pressures at end expiration, because that's the point in time where the pressures are almost equal, so there's not much effect on the intracardiac pressures. So basically this is the order of pressures that we get. So sometimes, and I think it's a good idea to go first to the most difficult pressure to obtain, which is the wedge pressure. And why is that? Because when you put in the catheter initially, it still maintains its flexibility. You can maneuver it. So you have more chance of getting to the most difficult pressure that you want first, as opposed to getting it in the RA, RV. And by the time you go to the difficult part of the procedure, which is the wedge, you already have less maneuverability of the catheter. So I think it's a good idea to go to the wedge pressure first, and then come all the way back and obtain the rest of the pressures. But in any order, we are interested in getting a right atrial pressure, RV pressure, PA pressure, and eventually the wedge pressure. Okay. So this is from the most recent European guidelines, and these are the measured variables that we're interested in that should be in almost all right heart cath reports. So you can see that, and I think it's a good idea just to, you have these pressures in the papers that was distributed, and we're going to have a quiz at the end that probably should make a note of some of these pressures. What are the normal parameters? But we start with a right atrial pressure. Normal is 2 to 6. The pulmonary pressure systolic is 15 to 30 over 4 to 12, and then the mean is upper limit is 20. Used to be 25, not anymore. It is now 20. Wedge pressure normal is less than 15. We'll come to that. Cardiac output between 4 to 8 liters per minute. Mixed venous saturation between 65 and 80. And then you go ahead and calculate from these numbers. You calculate different parameters like the PVR, cardiac index, stroke volume, and etc. Okay, so let's get an example here. So this is a pressure tracing, and when we show these pressure tracings to resident and fellows in OSCE stations, the usual format is that they should be able to, first of all, identify the rhythm as a normal sinus rhythm, and then they should be able to identify that the scale is from 0 to 20. Ignore the one in the left here that says 50. This is from 0 to 20. And then there is a wiggly line that is most likely representing a right atrial pressure, and if you take a mean line of that, you'll get an answer of, or you get a number of around 11 or so. So right atrial pressure here is around 11, 12. Then we advance the catheter a little bit more, and now the tracing changes. Not only that, but also our scale has been changed by our technician, our CV technician. So they change the scale so that we can look at the whole waveform. And now this waveform represents a ventricular waveform. Most likely it is an RV waveform. It reaches all the way to 94, 93 systole, and end diastole of around 13, 14, something like that. We push the catheter even further. Now we're torquing it all the way to the PA. And now the waveform changes into this appearance. And this is now the pulmonary artery waveform. You can see the systole is the same. So there's no pulmonary stenosis because the RV and the PA have the same systolic pressure. And now the diastolic pressure has gone up a little bit. So it's now 33. And the mean here is around 52, 53, way above the upper limit of normal, which is 20. Now, if we keep pushing with the balloon up, our catheter is going to wedge one of the smaller pulmonary artery branches, and now you'll have this change in the waveform appearance. Again, the scale was changed to 20, and we see this line that changes with respiration. If we identify this point as, I'm not sure if there's a pointer here. If we identify this point as the end expiration, then our wedge will be around 14. Now, we'll talk about how to actually estimate the wedge pressure more carefully, like more precisely in a few slides. But this is a left ventricular pressure. And why do we do left ventricular pressure? Just to see if our wedge pressure is similar to the LVEDP, and in this case it is. So this is the LVEDP here. It's around 14, 15, something like that, and it's similar to the values that we obtain with the wedge pressure. So suggests that our wedge pressure measurements was accurate. Sometimes we cannot have a good wedge measurement, and if that's the case, then of course we go ahead and obtain an LVEDP just to get the similar information. Usually the EDP and the wedge are the same except in the case of mitral stenosis. Okay, so I'll probably just stop here for like a minute or two of discussion and see if there's any questions, any comments.
Perhaps I'll ask this to the audience. Do we have any specific comments from the floor? Abdullah.
Thank you, Abdullah. It was really good. When you have a very bad respiratory variation, what do you do with the wedge pressure measurements?
Sorry, you couldn't hear.
Respiratory variation, significant respiratory variation.
Yeah, this is an interesting question. So sometimes you'll see, especially in patients who have either morbid obesity or who have like pulmonary conditions, you'll see a large swings in the pressures, especially the wedge pressure. And there are multiple ways to, try to estimate where is the actual wedge pressure in that center. So one way is to just identify or localize where the end expiration is, especially if you have the help of the respirometer. The other point is you can just take like average of all of the numbers and use that. To be honest, I think sometimes you'll see the pressure dips even like below negative. And you can tell that this is not possible, not physiological. But in my opinion, you either take the average of the whole swing, or you just take where end expiration is. But I'm not sure. What do you think we should do in that scenario?
Yeah, perhaps I can briefly comment on it. I guess in the field, we still have a certain issue here of poor standardization of how to really, or where to take the reading. And in the guidelines, we have said at end of normal expiration, as you quoted. At the same time, your question is well taken. If it's very pronounced, what should we do then? And I guess my point is, if we have a certain cutoff, which is 15, to discriminate between pre- and post-capillary, in the field, we should use the same type of reading, which is end expiration to start with. However, what the guidelines also say, if we have patients who are obese, or COPD, for instance, is another example where we have quite prominent respiratory variations, there, in these cases, it may be more appropriate to indeed take the mean, because then the end expiratory will be artificially high. At the same time, what I observe for myself, but also for our fellows, is sometimes you get a wedge of 20, you believe it's right, and then the tube is out, you have these numbers, you have the pressure waveforms, and then you consider the echo, and there's no sign of any left heart condition whatsoever. So then the question is, why should or why would the wedge pressure be 20 if there is no left heart condition? So for that reason, I think that when we start doing an invasive diagnostic test and then consider what is the correct wedge pressure, we should keep the clinical picture and particularly also the echo findings in mind. And sometimes, even if you're quite experienced in doing this, you can be wrong. You think you're in the wedge position, and then it's 20, but you have in your head, well, the echo says there is no sign of any left heart condition. Why is it so high? Let's fiddle around a little more. And then all of a sudden, chuk, then you're in the right position. So it is not easy, it can be tricky, and even if you consider all the things that you have mentioned, like the pressure waveform characteristics and so on, you still can be in the wrong wrong position and misinterpret what you're measuring. It is tricky, and we have to keep that in mind. And for that reason, in my personal opinion, we are too dependent on the wedge pressure when making the diagnosis of pre versus post capillary. There are too many issues, challenging measurement, where to read, volume state, respiratory swings, and so on. Multiple problems, and we just have to be knowledgeable of them, and therefore it's great that you pointed this out.
And I think one other trick is to use the LVEDP, which in my mind is less susceptible to the swings and the respiration. Please.
Yeah, I have few comments because wedge is the hardest thing to get in right heart cath. It's the most variable that's up to changes. What I usually try to do sometimes, if the patient is in deep sleep, I try to wake them up, ask them to talk to me, so that I can exclude the deep inspiration, expiration, and then probably they will not have as much. Other than that, if they are intubated patients, especially intubated patients, because I've seen a lot of wedge form of 25 in an intubated patient, and the patient was actually fighting the ventilator. They were having an excessive intra-abdominal pressures, so we need to give more sedation to those patients in order to minimize increase in intra-abdominal pressure. Asking the patient to talk to you or overtaking the wedge is one of the really good things. And sometimes if the wedge form is very, there is a lot of ringing, probably sometimes what I do is I aspirate some of the blood, so I make the blood as the media that transfer the waveforms, and usually it does give me a more stable waveforms in wedge readings. Other than that, if I really think this is out of proportion and I really need to know because this patient is a bit obese, this patient might have HFpEF, I will do an LVEDP at the end if I don't have any other choice. Thank you.
Yeah, very important. Thank you very much. Thank you.
Okay, so when we're doing right heart cath, we should be careful about some of the pitfalls of the right heart cath. So we should be able to identify the normal waveform. In this example, the normal waveform is the one in the left, so it's called an optimally damped waveform. The one on the right, you can see it has less of an upstroke, so this is a damped waveform, and the one on the far right-hand side is an underdamped waveform. So usually these pitfalls or these shapes of waveforms that are not optimal are usually related to some technicality. So what you do is usually you either aspirate some blood to fill the line or flush it with saline or make sure there are no kinks, and usually that will help. To be honest, the smaller the catheter, the more likelihood that these suboptimal waveforms you're going to have. So if possible, you go with the biggest size catheter that you can and for a particular patient. But usually you see these with a 5 or 6 French catheter, not so much with the 7 or 8. Now, As we said, the most important pressure that we're interested in is the left ventricular filling pressure. So there are multiple ways of measuring that pressure. One is the wedge pressure, second is the EDP, and third is the, if you're lucky and you have a PFO or an ASD, a direct LA pressure measurement. So how do we confirm that we have a accurate wedge position? Number one is we're going to see a typical waveform change from the PA into the wedge. In fluoroscopy, you'll see that the balloon is static while the rest of the catheter is moving with the beating of the heart and breathing and the respiration. You can aspirate some blood from the tip of the catheter, and when you assess the saturation, it should be an arterial saturation reflecting LA saturation. And if you inject contrast, there should be no reflux back of the contrast. So these are the ways that you can ensure that you have a proper wedge position. Sometimes, as mentioned, despite all of this, the pressure is not very accurate, and it needs some experience and also correlation with the patient data, so you can be confident of your reading. So let's take it a step further, and although it's rarely that we see these nice waveforms in practice, but let's just try to understand what are the basics of the pressure wave measurement. So in general, we have two upstrokes in the any pressure wave and any wedge pressure tracing. So we have the A wave and we have the V wave. So the V wave occurs right after the T wave on the ECG. The A wave occurs right after the QRS complex. So if you draw a line down from the QRS complex, you'll hit the A wave. If you draw it down just after to the T wave, you're going to hit the V wave. Again, this is in theory. In practice, it's rarely that clear. So the idea is we should not include the V wave in our assessment of the wedge. We should look at the A wave and look at the top and the bottom of the A wave and take the average of that. So in this particular example, the top is 15, the bottom is 7. So you take the average of that. They're like 22, the average is 11, so that's your wedge. Now, the problem is if you have what's called a large V wave. And this is a problem, especially if you depend on the computer for estimating your wedge pressure, because the computer will take the average of the whole thing without localizing the A wave in particular. But look at the example on the right-hand side, and you'll see that the dotted line, the line at the bottom, is the actual wedge, but the computer read it as the solid line. Why was that? Because the computer incorporated the large V wave into the calculation. So we got an overestimate. Please.
May I comment here?
Yeah, please.
I mean, this point is well taken. On the other hand, what we want to do, we want to discriminate between pre and post capillary. And the reasons here that you list, and I realize that this is published work, but the reasons that are listed here are reasons that are indicative of left heart disease, namely severe MR or the distensibility of the LV or the LA. So both underlying causes of a left heart condition predisposing to post-capillary as opposed to pre-capillary PH. So one may also argue that the V wave is a natural component of your filling pressure, and it should be integrated. So there are also two ways of interpreting that. I'm in favor of just including the V wave in the integral that gives you the wedge pressure, because it is indicative of left heart conditions.
I would agree to some extent, because sometimes we have these giant V waves, like where the V wave reaches up to like 50 sometimes. So if we take a wedge and the patient is lying flat comfortably, not having any shortness of breath, so in someone with a V wave of 50, if you took that as part of the wedge, then your wedge will be 30, 40. You cannot have someone who is having a wedge of 30 and they're just lying comfortably without any distress. So to me, I see the point if you're like, it reflects the post-capillary components, but I'm not sure. And again, this is again part of why the topic of wedge pressure is not an easy topic, and it's not very well standardized. There are multiple different conditions where But I think we all agree that if you have someone with a V wave of 50, you're not thinking about precapillary whatsoever.
Sorry, one more thing. Actually, excluding a V wave is correct thing, because in heart failure, in left heart disease, we do exclude the large V wave, although they do have a large V wave. There are other causes in the left heart disease. In the left heart disease, there is a VSD that can predispose to precapillary pulmonary hypertension. So they will have a large V wave without having any problem in their left-sided filling pressures. So probably a large V wave should be excluded, but we should be at least careful. If we have like a borderline mean of A wave and a large V wave, probably maybe we can give a fluid challenge, we can make the patient exercise or do some pedaling, and then we reassess the wedge. But in excluding V wave, a large V wave, that would be a stretch, because those patients might have not just a high LVEDP, they might have a moderate MR, where like someone with rheumatic heart disease, especially in our region, they will have rheumatic heart disease and they will have moderate MR as well as PAH, and we've seen those patients. They developed MR while they are PAH patients. So including those patients, probably we're doing more harm than good. Thank you.
Yes, perhaps one more comment there. I can tell you that we just completed an analysis in more than 3,000 patients that's unpublished yet, where we used a hemodynamic modeling approach, computational modeling, and patient data, and then looked for the reasons of a high V wave. And the mitral regurgitation, which we all think is of importance, but of rather minor importance if you consider left atrial stiffness. And this is a problem also in patients who have undergone electrophysiological procedures causing then a stiff LA. But again, my personal opinion would be that maybe we make a mistake if we exclude it. But I mean, perhaps we're getting too much into detail here, but it's important to at least be knowledgeable of the potential reasons for a high V wave, and then you can still make up your mind whether you should include it or not.
Excellent.
Okay.
All right, so this is the answer to your question, Dr. Abdullah, the patients with large swings. So you can see we either look at where the end expiration is, or we just take the average of the whole cycle. So those are the recommended methods. But if you have that, then I think we're destined to a not very accurate wedge, regardless of the method that we choose. Now, what about the fluid challenge? So, and again, this is a good example of seeing the patient before right heart cath, understanding the echo and understanding the clinical context, and then estimating what is the wedge going to be. And then if you see a result that is not to your liking, meaning you would think that this patient meets all the criteria for someone with a high wedge, like a diabetic, obese, hypertensive patient with leg edema, we would think that their wedge is going to be high. Let's assume that you do the right heart cath and your wedge now is less than 12. Would you believe that in such patient? The answer, you should not, because it's going against your predetermined assessment. So in those scenarios, a fluid challenge or an exercise would be a prudent thing to do. So in our lab, we typically do a bolus of 500 cc and then remeasure the wedge. And as you can see in this example, this is someone who had all the findings of or all the reasons for high wedge, but when you do the wedge pressure, it's 12. Would you believe that? The answer is you should not. So you give them fluid challenge and suddenly the wedge is now 22. A normal person, someone who has no left heart problems, they should be able to tolerate a 500 cc of fluids without any significant rise in their wedge pressure. Just for the sake of time, I think I'll just skip the over-wedging, under-wedging. Be careful because the PA can rupture. So especially if you inflate the balloon in a distal branch, that can happen, and usually it's deadly. So try to inflate the balloon only in the main PAs and preferably under fluoroscopy. And if you do inflate them slowly. And if you feel any resistance, you should stop inflating and just look what's going on under fluoroscopy. To complete the picture, you should be doing shunt assessment, so taking samples from SVC, IVC, RA, PA, and you should suspect a shunt if you have oxygen saturation step up of more than 7% from one chamber to another, or if the PA saturation more than 75%. Finally, cardiac output assessment. So why do we do that? Because the cardiac output, cardiac index are both prognostic markers. And the way we calculate the PVR is we have to use cardiac output. So PVR equation is there, mean PA minus the wedge over flow, which is cardiac output. So in general, the gold standard method to assess the cardiac output is the FIC method, but it's rarely done in clinical practice. It is very cumbersome to do. So instead, we use the indirect FIC. So basically, we estimate the oxygen consumption of the patient based on their gender, weight, etc. And then we do multiple calculations. And anytime we start doing calculation and estimating things, the accuracy of our work is less. So that's why it's preferable to use thermodilution as a method for assessing the cardiac output, which is the recommended method. There are some limitations, of course, in patients with shunts or TR, but basically the idea of thermodilution is that you inject some saline with a known temperature in the right atrium, and then the thermistor at the end of the catheter will measure the change in temperature. If you have a rapid change in temperature, it means that the heart is beating normally or supernormal. If the change in temperature takes a long time, that means, like in the blue line here, that means the heart is not really pumping vigorously, and that the change in temperature takes a long time to normalize again. So that's the idea behind thermodilution. This is the cardiac output equation by FIC. I think it's beyond the scope of this lecture. And then there are, as we mentioned earlier, there are multiple things that we have to calculate. So the cardiac index, pulmonary vascular resistance, TPG and DPG. Again, we can discuss those if we have time. So let's just see an example here. This is a lady who's 48, came in with shortness of breath. She has high PA pressures on echo with the dilated chambers, and the VQ scan was unremarkable. So I think we've seen this before. So wedge pressure here is 11. Systolic RV is around 93. PA is 93 over 33, mean of 52. So wedge pressure is around 14. EDP is the same. So these are the baseline hemodynamics. So this goes with a pre-capillary pulmonary hypertension. Cardiac output is 4.4, 4.8 by thermo, 4.4 by FIC. And then PVR you calculated to be 8, TPG 30, DPG 10. And then we give nitric oxide, and as you can see, there's no significant change in the pulmonary artery pressure. 52 dropped to 42, so it did not meet the criteria for vasoreactivity because it did not drop less than 40. So this patient meets the criteria for pre-capillary non-vasoreactive pulmonary hypertension. Now, each one of you, maybe we should stop here for a minute or two for questions, and then we can go to the quiz.
Thank you for...
Sure, do we have questions, please?
Yeah. Thank you for a good talk so far. I'm Khalid Saleh from Cleveland Clinic, Abu Dhabi. So a question for probably both of you. In terms of the waveform, even if the waveform is excellent and good fidelity in obesity, there is an article from Cleveland Clinic, main campus, showing that obese patient, even if you get it like the perfect wedge, it's going to be overestimated, and so is the mean pulmonary artery pressure. And if you look at the obesity paradox and pulmonary hypertension, that could be an explanation that these people actually don't have pulmonary hypertension to begin with. Mm-hmm. I would like to hear your thought about this, because they found out, I think 30% of these people, when you put the esophageal pressure monitor, they don't have pulmonary hypertension. And I think that's put an end to this question of obesity paradox, because they have better outcome. So what do you think? Should we put the esophageal monitor in obese patients?
Do you want to comment?
I mean, it really depends on the clinical context. So if you have someone with an RV that is dilated, they have like clear etiology for pulmonary hypertension, be it CTEPH or whatnot, it's hard not to believe that they have underlying pH. And I mean, yeah, if the margin is very small, it's not going to affect treatment decisions, then we're not going to disagree on like 3, 4, 5 points in the pulmonary pressure measurements. But if it's significant, I'm not sure that we can deprive patients from further investigation or treatment because, I mean, you got to believe the pressure that's in front of you. But is there any correlation with esophageal pressure? Yeah, it makes sense, but I have no clear experience on that, to be honest.
Okay. Agreed. Further comments?
Okay, so in the paper in front of you, there are 3 examples of different clinical scenarios. And the idea behind this quiz is we're going to do it the other way around. Instead of showing you the pressures, this time I want you to estimate the pressure for me based on the clinical scenario. So for each one of these, so let's start with number 1. We have a 30-year-old lady with severe idiopathic pulmonary arterial hypertension. And each word here is chosen carefully. She has NYHA class 3 symptoms and her JVP is raised. So let's go ahead together and try to estimate what is going to be her hemodynamics. Oops. So let's start with an RA pressure, RV pressure, PA pressure, and wedge pressure, and then cardiac output. I'll give you a minute to think about that. Let's just do it one by one so we can, I think. Okay. So what do we think her RA pressure is going to be? So let's choose a number. So it's because we're going to use those numbers for further calculation. Let's stick to a number. 15. Is there anyone that objects with 15?
Well, RA pressure, right?
Yeah. It should make sense, right? I think 15 is okay. If you're around like 10 to 15, I think, and why do we say that? Because she has a high JVP. So high JVP, I mean, her RA pressure is going to be more than 8 for sure. What about the PA pressure? Just estimate from just what do you think is her PA is going to be based on the brief clinical scenario here. 100? Let's say she's newly diagnosed, yes. Systolic PA. So if you say systolic PA of between 60 to 100 to 90, I think that would be okay, right? What about the mean PA pressure in someone with this description? So we all agree that it's going to be more than 20, but if she has NYHA class 3 symptoms, her mean PA would be around. Sure. We're not, but the idea is just to practice it.
63.
63. Let's choose something that is easier to help us with the calculation of PVR. So let's say her mean PA is 50. Just bear with me. So what about the JVP? Oh, sorry, not the JVP, the wedge pressure. 8. So now we have a systolic PA pressure of 90, mean PA of 50, and a wedge of 8. Let's go ahead and calculate her PVR. Oh, sorry, what about the cardiac output? Cardiac output of 2 is too low. So
3.
3 would be good. Okay, so what's the PVR now? We have mean PA of 50, we have a wedge of 8, and we have cardiac output of 3. So 42 over 3, which is 20, something around that, okay? So 20 what's in. Okay, let's go ahead and look at the second patient. And again, there's no true answer here. It's just an estimation to help you go through the practice of hemodynamic. So 25 with scleroderma, she's very active and has no symptoms. A screening echo showed a normal RVSP of 30 millimeter mercury. So what's her RA pressure? Sure, that sounds good. What's her PA pressure? Let's say systolic over diastolic over mean. Oh, sorry, and mean. So you would believe that the echo is accurate and you will choose an RVSP of 30? I think that's a good guess. A mean of 20? 20 would put her at the borderline, so sure, I think her mean would be 15 to 18, something like that. What about her wedge pressure? Again, 8 would be another wedge pressure here. So cardiac output in this patient? 5 is reasonable. So PVR, without doing the calculation, should be less than 2. Okay. Does anyone have a different opinion? Please, go ahead. Yes. Let's say she just completed the Riyadh Marathon 21K. Okay, I will add that for next year. Okay, so scenario number 3. 70-year-old male with diabetes, hypertension, coronary artery disease. He has NYHA class 3 symptoms and he has bilateral leg edema. Echo showed LVH. He has normal LVEF and a severely enlarged left atrium. His RVSP was estimated at 60 millimeter mercury. So what do we think his RA pressure is going to be? Yeah, so between 10 and 15, sure. What's the PA pressure? Okay. So a mean of 35, something like that, sure. What's the wedge pressure in this patient? Okay, so we have a wedge of 20. So this is above the cutoff of 15, suggesting that this pulmonary hypertension is post-capillary pulmonary hypertension. So question, do we need to do a fluid challenge for this patient? So he already declared himself as a high wedge, so there's no point of doing fluid challenge, right? We only challenge someone. So if this particular patient had a wedge of 12, then he would be a perfect candidate for a fluid challenge because you would not believe that. But he has a wedge of 20, so basically, the idea of all these 3 scenarios is we show you different patient characteristics from normal to pre-capillary to post-capillary pulmonary hypertension. Again, there are no right or wrong answers here. It's just an idea just to stimulate the thinking as a group. And with that, I'd like to conclude and thank you very much. Happy to answer any questions.
Thank you very much, Abdullah. Very nice lecture, and I think we pointed out specific caveats that we have with measurements, but also with interpretation of the hemodynamic variables. I think if I see this correctly, we still have a couple of minutes for discussion if you want. And I'm asking, are there more questions from the floor? Perhaps related to the last case, you listed there bilateral leg edema. Shouldn't we diurese the patient and fully recompensate before we do the hemodynamic assessment? What about the volume state during right heart catheterization?
Yeah, I think that's totally a reasonable thing to do, except in real life, sometimes we, for one reason or another, we get asked to do these cases. But as I said in the beginning, right heart cath should be done when the patient is in their euvolemic state in order to believe the numbers. And in fact, they should be over-diuresed so you can see the effect of fluid challenge. But this patient just happens to be like that.
Yeah. I mean, with this fluid challenge, we can also discuss this. The concern is that we lower the left-sided filling pressure to below 15 by the diuretic therapy, and the concern is that we then misclassify post as precapillary pulmonary hypertension. And to correct for that, we may perform this volume or fluid challenge. On the other hand, we may argue that if we have pure post-capillary pulmonary hypertension, which means that the increase in left-sided filling pressure is the cause for the pulmonary hypertension, the only cause, then if we normalize the filling pressure, be it by whatever medication, including diuretics, then we shouldn't have pulmonary hypertension anymore.
Yeah.
So if we have then a hemodynamic picture of normalized filling pressure, but yet high pulmonary artery pressure, we may also interpret that as that we have discovered or uncovered occult pulmonary vascular disease in a patient with HFpEF. I find that difficult to interpret. Can you perhaps comment on that?
Sorry, you're saying if we do a right heart cath in someone with all the reasons for HFpEF, and we found that they have post-capillary pulmonary hypertension with a normal wedge, is that what your question is?
Let's put it that way. You cath the patient twice. Once in a situation with bilateral leg edema, too much fluid on board. And you have a wedge of 20. Then you diurese, and your PA pressure stays the same. Mm-hmm. But your filling pressure normalizes. Yeah. What does that then tell us? That would be, so to speak, a volume challenge in reverse.
Yeah, so the question here is what happened to the PA diastolic pressure? If it dropped down, then probably that's all volume related. If it didn't, then there has to be some form of a irreversible pulmonary hypertension, like a pulmonary vascular disease that is either directly due to the whatever left-sided insult was, or some other etiologies. But I would look at the PA diastolic pressure, and it should help me estimate if this is all volume-related PA pressure increase, or is there's some irreversible component there.
Well, or good point. So it takes time for the reversal of the pressure. On the other hand, I'm just challenging this whole concept a little bit. On the other hand, we have seen in patients with documented CTEPH, a significant number of these patients have a post-capillary component. So that doesn't, we're always arguing, is it group 1 or group 2? But in fact, it could also be other entities and other subgroups of pulmonary hypertension, and I guess we have to keep that in mind in this context. So even if you...
And I think that's probably the reason why the guidelines recommend doing right heart cath in an expert center, because not that they have, like, they're smarter than the other people, but they are exposed to like all these different cases, different etiologies on a regular basis. So probably they have more broad understanding of the different explanation for different hemodynamics variables.
Yeah. Any further questions? I don't see any more. So then, thank you very much. Very nice lecture. Thanks for attending, and then we close this session. Thank you very much.
السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. Good evening, everyone. So my name is Dr. Khalid Al-Abaidallah. I'm consultant pulmonologist, pulmonary hypertension at Prince Sultan Military Medical City, Riyadh. I'm the program director of the Adult Pulmonary Fellowship Program. It is a pleasure to see so many of you here today for this important workshop on risk stratification and treatment for pulmonary arterial hypertension. Today we are honored to have Prof. Luke Howard. Prof. Howard is professor and consultant pulmonologist at Hammersmith Hospital, Imperial College of London, UK. He has many contributions in the pulmonary hypertension field. He had been attending and presenting in many international conferences. His role in publication and research in the field of pulmonary hypertension, as well as his role at the European Respiratory Society. This workshop on risk stratification and management of pulmonary arterial hypertension will provide us with a valuable insight on how to risk stratify your patient, to set goals for therapy, and to guide initiation of medication, and put like a map for your follow-up with your patient to modify medication if it's needed. As you know, our main goal is to achieve low risk status, as those patients will have a better survival and less morbidity. Without any further ado, I would like you to please join me in welcoming Prof. Luke Howard.
Thank you very much. It's great to be back. I've put together a lot of slides, but we'll get done by 6, because when you've got cases, you can just keep going and going and going until you run out of time. So these are my disclosures. I'm going to talk a little bit briefly about the concept of risk stratification, and then I'm going to get into some cases. So we have the 2022 European guidelines, which, and the treatment algorithm looks like this, and you'll note that it's split into patients with cardiopulmonary comorbidities and patients without cardiopulmonary comorbidities, and there's a different treatment algorithm. And you'll note that there's a risk-stratified treatment algorithm on the left, but on the right, there is nothing. And what the World Symposium suggested in 2024 is that certainly in the group which was involved in definition and classification, they said, we do not suggest the introduction, well, it's a bit late now because they already introduced it, but we do not suggest the introduction of a subgroup of PAH for patients with comorbidities. So I think there was a little bit of regret after the 2022 guidelines that when the algorithm went out, it just looked like somebody with comorbidities, you give them one treatment and then you leave them be. And I think this was just sort of rowing back a little bit from that to say that actually we should still be treating them aggressively. And in the subtext of the new treatment algorithm guidelines, or other recommendations from the World Symposium, in the text it says, if you've got patients with comorbidities, you might need to just tread a little bit more carefully as you introduce therapy. So we still have something that looks fairly similar to the 2022 guidelines, but of course we now have the introduction of activin signaling inhibitors, or rather just sotatercept for short. But otherwise, it's still a risk-based algorithm in terms of treatment. So in the middle, you've got this ellipse here with functional class, 6-minute walk distance, and BNP or NT-proBNP. These are the non-invasive validated markers for risk stratification. And they've been around for some time now. One of the reasons that they are used is because they are simple, accessible, and repeatable. But there is a recognition that it can be a bit more complicated than that sometimes. So you might have a young patient, for example, who walks very far, but who still has severely impaired hemodynamics. So there is the suggestion that perhaps while we use this as a simple approach, that we need to take it in the context of other things, for example, hemodynamics and echocardiography. So you see the changes in hemodynamics in the top in that swirly graph there with lots of things that you can look at, such as PVR, right atrial pressure, cardiac index, and mixed venous saturation. And then you've got some various parameters on echo, many of which are not in the guidelines for simplification reasons, but things like TAPSE, free wall strain, fractional area change, and so on. So why do we need risk stratification? Well, it's to guide therapy. And what pleased me about this is that something that I've been thinking for a long time is that really you don't need risk stratification to be that complicated. If you're presented with a very sick patient, you give them maximal therapy, including intravenous therapy, up front. If they're not so sick, we have good evidence for upfront dual oral combination therapy. So you have a binary decision. You either give them dual upfront combination or you give them triple with IV. So it's a simple one or other decision. But still, nonetheless, risk stratifying patients at baseline based either on a European approach or an American approach with REVEAL. This is the European approach. And at baseline, you can take a number of different parameters. So clinical parameters, exercise parameters such as 6-minute walk or exercise testing. There's BNP. So these are all reflecting RV function. Imaging on echo, so right atrial area, the TAPSE over the systolic PA pressure, the presence of an effusion, imaging measures on cardiac MRI, in particular the stroke volume index, and on hemodynamics, our old friends, right atrial pressure, cardiac index, mixed venous saturation, and also stroke volume index. And the way you approach this, if you're not familiar with it already, is anything you have in green is 1 point, anything you have in yellow is 2, and anything you have in red is 3, and you simply average up the points that you have, and that gives you either low, intermediate, or high. There's the French approach, which is FPHR, which is simply to count the number of low-risk criteria that you have. And if you're using the invasive criteria, you have functional class, walk distance, RA pressure, and cardiac index. And if you're using the non-invasive criteria, it's without the hemodynamic measurements and the BNP in its place. So following that, following your initial decision, you then have a 3-month assessment. And at this stage, it divides into 4 risk categories. Low, and then intermediate is into intermediate low and intermediate high, and then finally high. And so what you do is you scale up. If you're in low risk, then you continue. Intermediate low, then you add in either sotatercept if it's available, oral or inhaled prostacyclin pathway agonists, or you can switch a PD5 to something like riociguat. In intermediate high, at that stage, consider sotatercept or add in a parenteral prostacyclin, and if the patient's in high risk, then first choice is parenteral, and if not that, then sotatercept. And you keep building up and up until you're on maximal therapy to achieve the lowest risk possible. And so the 4 risk criteria are based on non-invasive tools, functional class, walk distance, and BNP, and it's the same approach in terms of averaging. The REVEAL risk score builds in quite a lot of these parameters, but there are also some parameters which you can't change. You can't change, for example, the top line, what your diagnosis is, whether it be heritable or connective tissue or portopulmonary. So that confers a worse prognosis. You can't change your sex. You can't change your age. You can't change whether you were hospitalized a week ago. So there are certain things you can't change, but there are other modifiable features which may change with therapy, which are below that, and many of them overlap with the European criteria. REVEAL Light 2 on the right-hand side takes out a lot of those non-modifiable changes, non-modifiable risk factors, and gives you something that looks very similar to the European score, except for the fact that you've also got heart rate, blood pressure, and EGFR. So, the important thing is to assess the risk at baseline, but even more so at 3 to 4 months. So let's come on to our first case. And at this point, I'm going to start to ask you to give me shows of hands as to what you'd have done. And I want you to put yourself in my shoes in 2018, okay? So this is a man who's 59 years old at that stage, diagnosed with idiopathic PAH. He's a non-smoker, but he's got a very low gas transfer. He looks like he's got connective tissue disease. but his serology was negative then. It's been negative ever since. No CT features of veno-occlusive disease, so IPAH, low gas transfer. When we do his baseline risk assessment, you can see there's a scattering of the risks in green, yellow, and red. And so when you do the averaging, he comes out as 2.0. So he comes out exactly as intermediate risk factor. I've actually shown you his full hemodynamic data on the bottom right. So he's got an MPAP of 46, cardiac index of 2.1, and he's pre-capillary. And I've also shown you the cardiac MRI data, which is interestingly got one green, one yellow, and one red. So the MR is giving you all sorts of conflicting information, but the stroke volume index there is in green. So we've got to decide, is he not high risk or is he high risk? So I'm going to put that up for you again. And I've told you he's intermediate risk, but he's got some high risk features. You can see those in red. His cardiopulmonary exercise test is awful, and he's got a gas transfer of 30%, which is one of the REVEAL scores. So I'm going to make it simple. You can either go for dual oral, or you can go for upfront triple with IV, because those were the choices available to me in 2018. So I'd like a show of hands for dual oral, please. Okay, is this going to be everyone going for triple, or is everyone abstaining? Right, triple with IV. Okay, so there are a few more hands. There are many abstentions. So, I'll be honest, went for dual oral with this guy. So, I really tried to make some of you say IV because I sort of laid it on thick about the high-risk markers, but the hemodynamics were generally okay. So, if you look here on the top right, you've got the survival according to the 4 risk strata at baseline and then at follow-up. And what you can see is the green line in the top matches up with the yellow line, whereas it starts to fan out and split by the time you get to follow-up. So in other words, the risk status at follow-up is really what defines the survival, the long-term survival of these patients. But it's a bit depressing, isn't it, if you look from this registry of how many people shift class. You've got this huge wedge of patients in the intermediate zone who don't really change much. You've got the lucky few who increase into low risk, and you've got some people who are actually worsening to high risk. So we're not really shifting the dial a huge amount, certainly in this particular registry at follow-up. And this is the Swedish data showing roughly the same sort of thing. And it shows you on the top 2 lines is the people who were low risk at baseline and low risk at follow-up in green, in blue, and the people who improved from another risk category into low risk in green. And as you can see, effectively, it doesn't matter where you start from, it matters where you get to at that 3-month hospital visit. So it's a really crucial time to make your assessment. So he got dual upfront combination therapy, and we reassessed him at this 3-month time point. And if I show you his risk criteria here, I've got him down as functional class 3, which is 3 points, 405 meters, which is 2 points. You'll see with this guy, he never moves out of functional class 3, and his BNP is now in green. So he is intermediate low risk, so I've highlighted that there. And so here is actual full hemodynamic data set. His mean PA pressure is the same. His cardiac index has gone up to 3.1 liters per minute per square meter. And his PVR has come down almost to 5 Wood units. His stroke volume index is 43, so it's still green. And his RV ejection fraction has improved. So he's done very nicely on dual oral therapy. So he's intermediate low now. After. He's now on 3 months, he's intermediate low. So since you raised your voice, what are you going to do for him now? That's exactly what we did. He was our first patient to go on commercial Selexipag. He came in on the 1st of April, 2019, which is when it became available to us in the UK. He was the first patient to go on commercial drug. So we put him onto Selexipag, and just to highlight, really the makeup of that trial, more than half of the patients were idiopathic, like him, more than half the patients were functional class 3, like him, and a third of the patients were on dual oral therapy, like him. So this trial was kind of designed for him. And it showed an improvement in morbidity, mortality, and effectively you can talk to the patients and say, this will delay your disease progression by a year. And it also applies to those people who are on triple oral therapy. So it seemed like absolutely the right choice for him. That's exactly what we did. And then we get to 12 months, and you can see he stays in European intermediate low. His BNPs come down even further to 17. He was not having such a good day, maybe on his walk test. He dropped to 369. He's stuck in functional class 3. And then at 3 years, he's in functional class 3, walking 420 meters, but his BNP's gone up. What are we going to do with him now? He's on triple oral therapy. The next stage is quite tough. Now, in the UK, I can't switch him from PD5 to riociguat because I'm not allowed that combination with Selexipag because it's too expensive. But I could give him IV. What would anyone else do? Huh? Right heart cath. Have you seen my slides? Absolutely. So here's a right heart catheter. His right atrial pressure is 4. His cardiac index is 3.1. His mixed venous sats is 73. His PA pressure is 30. His PVR is 3.8 Wood units. So what am I going to do with him now? Nothing. I'm really happy with the guy. Would you agree? They don't match. This guy is always complaining of symptoms. He's always breathless. But, so I agree with you. His BNP's just nipped over the line. If it was the fact he was in functional class 2, I said we're super happy. And I think this is a reflection of long-standing triple oral therapy. I think that it gets you there in the end. Okay. So, what have we learned from this case? That you can look at the functional class and the walk distance, and you can look at the BNP. Don't know why BNP is not on that slide, I apologize. But there are other things that you can give you valuable information. And sometimes when you don't know what's going on, you cath the patient. So I think that's what that case has shown us. And what's the additional valuable information we can get from cath? Well, here's some data from the French group published by Athénée Bouclé, who's here. Probably not in this room. Not much I could teach her about risk stratification. But she's at the conference. And so here they looked at whether you could further dichotomize patients in these intermediate low and high risk groups with stroke volume index of 37 or more, or mixed venous sat of 65%. And yes, indeed, you can. So if there's doubt and you're in the intermediate low risk group, then the beneficial hemodynamics can push you into a lower risk group. So it's quite useful. So that's where we are with this guy. I'm very happy with him. And then, last year, he's in functional class 3 still. He's still walking 420 meters. His NT-proBNP is now green. And we reinvestigated him to try and put him into the PROSERA study, which is inhaled seralutinib, because he would have probably fitted that study. But then when we cathed him, we found his PVR was still at 3.4 with units, so he didn't meet the entry criteria. He's actually a bit hyperdynamic now. And what had happened, and if you look super close, you can see his mixed venous sat is low, is he'd become anemic. But his PVR is 3.4. He's well maintained on triple oral therapy, and so we're happy with his status. And there you can just see how if you now add in the stroke volume index and mixed venous saturation, you can get this lovely separation of the curves. I always look at this and think, that's great, but I don't have 6 treatment options. But what it does is it helps you decide maybe on whether or not you're going towards more high-risk therapy or stick on low-risk therapy. So I suppose what I'm illustrating here is while we present risk stratification like this, nice and simple, actually it's a bit more blurry, but in reality it's not even that simple. It looks more like this. It's a mess, okay? And so that's why it's still important for us to use our clinical judgment in terms of decision making. And one of the things that highlights this mess is when you compare REVEAL risk stratification with the European approach. And the European approach can be either the Compera approach, which is averaging up the numbers, or the French approach, which is counting the number of low-risk variables. It's a complicated slide, so take a deep breath. Now, what you're looking at in the bottom 3 rows is all the patients categorized as high risk by REVEAL. So in other words, these bottom 3 lines should all have high 12-month mortality, and you can see they do. But you can see the 3 lines in there, embedded in there, are low, intermediate, and high risk as per Compera or French. So you can see that there are a number of patients who are high risk by REVEAL, who are low risk by the European criteria. And that highlights probably because they may be older, which REVEAL takes account of. They may have connective tissue disease or portopulmonary hypertension, which REVEAL takes account of, which the European risk score doesn't. So there are these other factors, so we need to not just look at simple risk scores on their own. And so these are the things that went into the analysis for REVEAL, and the ones highlighted in red are the ones that came out as independently predicting of outcomes. So gender, age, renal insufficiency, comorbidities, DLCO. We know that those patients with a low DLCO really don't do so well on treatment. There's nothing about that in the European risk stratification. I'm sounding a bit anti-European, aren't I? But then I am British. So what about physician assessment then? How do physicians assess risk just by looking at the patient? Well, what you've got on here is another slightly difficult graph to get your head around. 3 categories, low, intermediate, high. That's what the physician said. I said, I think my patient is low risk. 20% of the time, the risk score, calculated risk score, was in agreement with the physician. So you can see there's quite a disparity. And when the clinician said they're high risk, then only 31% of the time was the actual risk score high risk. So there are things that the physician is taking into account that the risk scores aren't. Who's right? And what's the main reason behind it? And the main reason behind it is that when you look at the data that the physician has in front of him or her, by and large, they have functional class 95% of the time. I mean, I don't know what you're doing if you're a clinician and you can't work out the functional class, but what you can see is that less of the time you'll have a 6-minute walk, and below that NT-proBNP, and then hemodynamics maybe only 20% of the time. So in other words, physicians are generally basing their risk score on functional class alone, which can lead you into a difficult situation. As we saw with my last patient, who's functional class 3, always 3. Doesn't matter whether he's having a good day or a bad day, he's always 3. I've got my reasons for suspecting that, but I won't go into that. So functional class doesn't tell you the whole story about risk. So here, 2 columns, functional class 2 and 3, and you can see in functional class 2, then if you look at REVEAL, then 10% of those patients are high risk. So the functional class is not always pinpoint accurate. So, another case. Right, I've got a 63-year-old woman with portopulmonary hypertension, and she's functional class 3. Ask her to do a 6-minute walk, she can't do it. So you could say maybe she's functional class 4, but there are various reasons, knee pain and this, that, and the other. But she says she's functional class 3. She's not symptomatic at rest. She's not syncopal. But her BNP is 27. I don't know how well that projects, but her right atrial area is intermediate risk. It's 20 centimeters squared. No effusion. You can see her hemodynamics. So I would say she's got mild to moderate pulmonary hypertension, moderate pulmonary hypertension, but with well-preserved cardiac function. A cardiac MRI shows good RV ejection fraction. REVEAL risk score is high risk. So, what's your treatment strategy for this patient? So I'm going to start with monotherapy. Dual oral combination therapy. A few hands going up. Triple therapy? A few hands going up. Oh, interesting. Okay. Maybe I should get the plane home. We gave her monotherapy. Okay. Her BNP is 27. Her RV function's amazing. 3 months on monotherapy. We'll repeat the cath, PVR 3.5. So a lot of the things that are going into her risk are things that are not related to her pulmonary hypertension. So you can chuck as much medication as you want at her. You're not going to change her outcome from her pulmonary hypertension, in my view. Now, that was probably 6 or 7 years ago. Maybe we'll give her dual therapy now, but I think this argues that you can take a sequential approach. You might say, okay, I'd probably give her monotherapy, and I'd reassess her very soon, and then maybe give her dual therapy. But if you saw these data in front of you now, in a patient with portopulmonary hypertension with high flow, what are you going to achieve? So I think it's debatable now that we're 7 years down the line whether we should give dual upfront combination therapy. But what this tells you is that sometimes you just have to look a bit deeper than the risk score. Now, I've got a 60-year-old man who presented about 7 years ago as well with IPAH, coronary disease, low TLCO, hypoxemia. He's an ex-smoker, and he has got most of his things here in green. He's got some yellow, so his 6-minute walk's down. And then his cardiopulmonary exercise test shows a very high VE/VCO2 slope, which agrees with the low gas transfer, and a bad cardiac index of 1.5. So his REVEAL score is intermediate. And I'm going to give you some options. Initial monotherapy, upfront dual, upfront combination with IV, upfront triple oral. So who's going for one? Mono. Sorry? The reason I didn't put it up is because it's completely normal. Yeah, sorry, it's not a trick question. Okay. But yeah, because you're thinking, he's got a lot of risk factors for cardiac disease, so absolutely. You're thinking, could it be group 2? No, it's a good point. It's definitely group 1 after cath. Upfront dual combination, who's going for upfront dual oral? So we've had a tiny bit for mono, waving there for dual oral. Upfront with IV therapy. Anyone? Triple oral? No one's really sure. Do you know what? That highlights the fact that this is a good case. Or it highlights the fact that you're completely bored out of your brains. I'm going to take the first, right, that this is a good case and you're not sure what to do. We went with dual oral. Now, why did we go dual oral with this guy and not with the last patient? His cardiac index was 1.5. He's got idiopathic disease. And yes, he's got comorbidities, but this was before the 22 guidelines when we didn't quite recognize maybe these phenotypes so much. I mean, we used to call this IPAH with low gas transfer, which is kind of the same. So we gave him dual oral therapy. He responded quite nicely, 450 meters on his walk test. His BNP is now less than 10. And we recathed him. His mean peak pressure is 22 with a PVR of 3.3 Wood units. He's still got this low cardiac index. He's got impaired cardiac function somehow. So that's what's driving his intermediate risk here. Now, so when would this have been? This would have been about 2018, 2019. What would have anyone have done here? We didn't do anything because we didn't have Selexipag at that point. And with those hemodynamics, I wouldn't give him intravenous prostacyclin. Anyone do anything else? I mean, yeah, you could switch to Rio. You could switch to Rio. In fact, I think we did at some point. We listed him for transplant because he was just about on the cusp, age 60. He was otherwise quite well. And I could see this man was really symptomatic. Despite walking 450 meters, he was on high flow oxygen. He just had terrible gas transfer. And I thought, I can't make your hemodynamics much better than that, and you're still terrible. So there's something else going on. So we listed him for transplant.
Can I ask you a question? Because this patient is an ex-smoker. Because we've seen those patients with bad emphysema, and they tend to have a low cardiac index regardless of if their PA pressure is not that high. And we've seen this over and over and over, even in those, and their PVR is derived by the low cardiac index rather than by the high PA pressures. And probably if he has emphysema, maybe a lung transplant is the solution for both.
Yeah, I know. He never got a transplant, sadly. He then deteriorated about 6 years later. But yeah, the low cardiac index is a bit of a puzzle, but maybe it's related to the comorbidities. He didn't have any obvious coronary lesions that we could have done anything about. We looked at his coronaries, but it's an interesting one. And what I could never quite work out was his mixed venous saturations were quite well preserved, but that was just because his hemoglobin was high, because he was hypoxemic. Anyway, so it's an interesting, and we did wonder at some point about putting him on Selexipag, but we weren't quite sure if he was going to tolerate it, and with those hemodynamics, we weren't quite sure. We thought there were so many other things driving his symptoms. Now, how am I doing for time? Brilliant, I'm doing okay. Right, so I've got a couple more cases. This is a 23-year-old. Obviously, it's not case number one. You can see how I just chucked a whole load of cases together. And she was seen in February 2017. And she'd had 1 year of increasing breathlessness. She was breathless on stairs, no ankle swelling, no presyncope, no syncope. Family history, her mother had an atrial septal defect, and her maternal grandfather died of sudden death in his 40s. She was a smoker of 10 a day. She also smoked cannabis. She didn't drink much alcohol, no other recreational drugs or risk factors, and she was on no medication. This is her ECG, which I think you'll agree is fairly consistent with the diagnosis of pulmonary hypertension. And she's got first-degree block, maybe, almost, yeah. Her echocardiogram shows a severely dilated right ventricle, with normal function. TAPSE was a bit down, 1.7. S prime was down a tiny bit at 10. Mild TR, very high peak TR jet, 5.4 meters per second, short acceleration time, and a normal right atrial pressure. Right atrium a bit dilated. And she had a 17 millimeter atrial septal defect, 17 millimeter shunting left to right, and her LV was normal. So we go through the diagnostic process as it was back then with the 2015 guidelines. We considered left heart disease and so on. This is her lung function. She's got normal lung volumes. And although she's got a left to right shunt on her echo, she's got a slightly low gas transfer. So this is clearly a pulmonary vascular process going on. Type 1 respiratory failure. And CT scan shows nothing else. The CT pulmonary angiogram showed the atrial septal defect. She had normal VQ scan with possibly a bit of renal uptake. I think you might be able to convince yourself. So there's clearly some mixing and no other, nothing else diagnostic of any other form of PAH. She had a cardiac MRI, which showed a QPQS of 1.3 to 1. So she's got a slight left to right shunt. And the right ventricle is severely impaired, severe RVH, pressure and volume loaded, and normal pulmonary venous drainage. And then finally, her cardiac catheter. So she's got very high pressures. Mean PA pressure is 65. Right atrial pressure is conserved at 6. There's your wedge pressure, 12. You can see her saturations. There is a PA sat of 78, so the QPQS is not is only 1.3 on this, which matches the MRI very nicely. A pulmonary flow index of 2.6 liters per minute per square meter, and a PVR of 14 Wood units. So, I've got a question for you. Is this IPAH with a bystander atrial septal defect, or is it congenital heart disease?
How big is the congenital defect?
17 millimeters. Is that what your question was?
Yeah, it can be both.
It can be both. It can be both. I mean, maybe it was smaller before the right atrium dilated up. Yeah. Okay, look. it can be both, and at this stage, maybe it doesn't really matter.
Treatment-wise, it's the same.
It depends if you're going to think about closing it when... Anyway, who's going for IPAH with... Yeah, okay, so hand going up there. Who's going for the second diagnosis? Okay, there's an even split. I mean, we said it's probably number one, just because the guidelines say that if you've got an ASD less than 2 centimeters, then that can't really account for your pulmonary hypertension. But we all know it's a bit more complicated than that. And like you say, does it really matter at this stage?
I think she should go for genetic counseling, because a lot of those patients, they will have BMPR2 gene positive.
I had that in as a third question and I took it out. But she has had genetics done because she's got some weird stuff going on. She's got some funny teeth. Her eyes are a bit strange. She's got something wrong with her irises. I can't remember, maybe something with her fingers. Anyway, we got her reviewed by Richard Trembath, who discovered the BMPR2 gene. So, like, you know, who else are you going to ask? So she's had full genetics done. Yeah, absolutely. Good point. So this is her risk stratification. So a bit like the last few patients I've shown you, she's young, right? She's walking more than 440 meters. She's walking 475, and she desats down to 79% because of that hole. She does a cardiopulmonary exercise test, so peak VO2 is 15, which is green, but it's 40% predicted because she's young, so that's not great for a 23-year-old. Her VEV-CO2 slope is 74, very high, mainly probably because of the shunt. Her BNP is 125, and by reveal, she is low risk. She scores 5. So she's got a PVR, she's got PA pressure of 60-something. I can't remember what it is now. Okay, I mean, right. I know this was like 2017, but, you know, okay, who's going to go for monotherapy? No, okay, because you're not saying this is congenital disease PAH, right? So who's going to go for upfront dual oral combination therapy? Yeah, lots of hands going up. Who's going to go upfront with IV? No one at this stage. I'm super nervous about people with big holes in their heart giving them IV, because I've had a couple of people stroke out, even on anticoagulation, so I don't like it. I'll use it if I have to. Who is just going to go and close the ASD with a fenestrated device? You're going to kill that. All right, there's the door if you want to do that, okay? She's going to throw you out, okay. Who's going to go for upfront combination therapy and then a closure device? No. Well, you might consider it, but no, okay? I mean, probably it's not going to work, okay? But, so, we're all going for dual upfront combination, thank you. We now agree for once. And we gave it tadalafil, ambrisentan, and back in the day, we were still anticoagulating patients. 1 week later, I can walk up the stairs. I don't feel breathless. I feel amazing. 1 week. So that crucial 3-month follow-up, what happened? So now she's pretty much gone green. Her walk distance is 480 meters. She desaturates to 92, so we've clearly improved matters. Her peak VO2's gone up to 18. Her VEV-CO2 slope's come down. Her BNP is a bit disappointing. Echo hasn't really changed. She refused a right heart catheter, but her TRV's gone from 5.4 to 4.4. She had an MRI. Her RV ejection fraction's gone 58%. But whoa, what's happened to her QPQS? 2.5 to 1, which is, you're thinking, wow, what's going on? Now, also, what happened is her hemoglobin halved in 3 months on warfarin due to menorrhagia. So that's probably what was driving this huge left-to-right shunt. So what do? Stop the warfarin, administer iron, and then get her back. Still, you know, you'd see, if you saw those data, you'd be thinking, ooh, maybe it's closable anyway. But I just put that one up there because what you do is you treat the anemia first. And then we followed her up at 12 months. And she's still in quite a good place. We didn't have a 6-minute walk because she got on the bike instead. That's kind of stable there. Her BNP, it's still not great. I'm still not wildly happy with her, but she's functional class 2. So, What are you going to do at this stage? Supposing you've got all the drugs available apart from sotatercept. Is anyone going to add in selexipag?
Yes.
Okay. We would have done, okay, but she's functional class 2, and at that stage, we could not administer selexipag in functional class 2. But that's exactly what we would have done, because she's young, she might be functional class 2, but her exercise capacity is not great. Her BNP is up there, and we want to improve things. If this was my daughter, this is what I would want, and that's how I always think about these patients. So, 18 months, now she's functional class 3. She's desaturating to 94%, 84% on a walk test, but still walking 4, 5, 6. Functional class 3, which should actually be in yellow. So that's a bit of a typo on my behalf, apologies. You can see her right atrial volume is increasing. We've got it in volume now, sorry about that, and her peak TR velocity is up at 5.5. So things aren't going particularly well at this stage. And so selexipag was added. And at this stage, we said, let's just have a look and see what happened, because I think that the hole had now got bigger because the right atrium had stretched. So we wondered, what if we can just make the hole a bit smaller? But you can see she desaturates. You do not want to close that hole, or you're going to be in deep trouble. So we did a cardiac catheter. Her mean PA pressure is up there on the top left. It's 65. Her PA sats, 78%. Sorry, I'm looking at this. That's her baseline. I was thinking, those numbers look familiar. That's the baseline. On the right, you've got her data. Her mean PA pressure is 53. Her PA sats are now 91%, and she's got a QPQS of 2.2. The PVR is 4.7 Wood units, but that's 7 Wood units indexed, and that's on triple oral therapy. And so the congenital people said, nah, we're just not even going to think about it. It's a shame, because you almost think, oh, if only I could decrease that shunt, I'm sure that would help. But they just said, no, we're steering clear of this. So then we get to 2019, just before COVID. She's walking now 420 meters. She's still desaturating a lot, which kind of justifies the decision not to make that hole smaller. Her NT-Pro BNP, sorry, we've gone from BNP to NT-Pro, it's 1,500. And at that stage, what do? She doesn't want IV therapy. I'm still nervous about it. At that stage, she went into a clinical trial with imatinib, and that's really stabilized her very nicely. She is going to go into a clinical trial in 2 weeks' time. She's going to have a CardioMEMS device inserted, and she's going to have a phase 2 study with a ZIP12 monoclonal antibody. Exciting. Anyway, so that's where we are with her. But she's still alive, and she's still in great shape.
What about sub-Q therapy?
Yeah, good call. We can't access sub-Q. So we were able to use treprostinil until about 2010, and then they tripled the price. And the NHS said no. Now the price has come down because of generics, and we're in the process of trying to get it approved. There we are. So, sorry about this. Now, my last case is a 56-year-old woman who presented almost a similar time to the last patient, with many similar features. Really interesting. She was a teacher. She was from the same part of Wales as this other patient. She was a runner, a cyclist, completely clean bit of health. Never smoked, no alcohol, no risk factors, and presented in June 2018. And she measured her running speed on Strava. And she'd noted that over a few months, you can see here her running speed, her time per mile had started to get worse. So it goes from the bottom up. So you can see how it was 8.5 minutes per mile, and then it went to 11 minutes per mile. So she was getting worse and worse and worse. She thought she was just unfit. And she got inhalers, this, that, and the other. She got this ECG, and it was completely ignored. I mean, that's scary, isn't it? I mean, anyway, So she got referred to us, went through the diagnostic algorithm. She's got normal lung function in terms of volumes, low gas transfer, slightly hypoxemic, normal CT imaging, and a tunneled patent foramen ovale. There's her CT. You can't really see the PF. Well, you can't see it there, but anyway, there's nothing to see apart from a big right heart. Her walk distance was 660 meters. It's a runner. She desats to 81%. Her echo shows a peak TR velocity 3.7. Dilated RV. Right atrium is not dilated particularly, and the bubble contrast echo showed a shunt. Okay, that's the information. You're seeing her in clinic. You've got a walk test. You haven't got anything else. You haven't got bloods. You haven't got. You've got the CT. What do you think she's going to be? Who thinks she's going to be low risk on all the tests?
This is rapid progression of symptoms, isn't it?
Sorry?
Rapid progression of symptoms.
Yeah, rapid progression, I'd say. Yeah, but yeah, I honestly thought she's going to be a great case. She's going to be low risk. We're going to treat her. She's going to be fantastic, and she's going to live for years. Right? Who thinks she's going to be high risk? Intermediate risk? Yeah, I mean, the answer is always going to be intermediate, isn't it? Because they're always in the middle. So we went through the diagnostic algorithm, no perfusion defects, and she had a positive ANA, but ENA was negative. So she was labeled idiopathic. This is her MRI scan. She had LV stroke volume was 35 indexed. The right RV stroke volume was 41 indexed. I don't know why the flow is the other way around, but there must be something to do with TR. And an RV ejection fraction of 33%. So this is her cath, mean PA pressure 48. You might have expected it to be a bit higher based on, her presentation. Her cardiac index 1.5, pulmonary flow index 1.5, with a PVR of 17 Wood units. So she's intermediate risk, you were right, 1.8. I had a hope she might be low risk. So what are the data? She's got a peak VO2 of 13 mils per kilo, which is not good, 55%, a VVCO2 slope of 76, which is terrible. So really bad gas exchange. And BNP was 471. So what would your first-line therapy be in this patient? Intermediate risk patient, mono. Who's going for mono? Dual oral?
Upfront combination.
You're going upfront, sorry?
Upfront combination.
Upfront combination, yeah. Oh, I'm sorry, I put sequential and then upfront. Yeah, upfront combination. Are you going straight, who's going straight for IV? No one, okay. So, maybe. Yeah, we were teetering on the IV. We were teetering on the IV. Had a nasty feeling about this case, so yeah. But you might think, go for dual oral, then see. And she was of the kind of, just give me tablets first, but I will consider IV. So we gave her tadalafil Ambry 3 weeks later. She felt amazing. But 3 months later, it wasn't looking quite so good. So she got a really good hit and then came down again. So where is she 3 months later? She's functional class 3, walking 660 meters. Which I know is a bit odd, but let's remember, this is a patient who is used to running around, and for her, functional class 3 is different from all of us. Her desaturation is about the same. Her VEV-CO2 slope hasn't changed. Her BNP hasn't really changed. Her echo hasn't changed. Her repeat cardiac catheter, a slight increase in cardiac index, her cardiac MR. It's a very ungratifying response to therapy. So what are you going to do now? Who's going for Selexipag? Who's going for switch? Who's going for IV? Yeah, okay. Yeah, all right. Inhaled iloprost, not really appropriate either for the other reasons. This patient needs IV. Exercise rehab. I had to think of a fifth question, right? So, what's the difference between those two last ladies that I presented, apart from one's double the age of the other? But they're very similar in some ways. One has an ASD, one has a PFO. They both presented with quite good walk distances. BNP's up a little bit. When you look back at the data, and I'm not going to go all the way back, the big difference was the cardiac index was dire in the second patient, and it didn't respond to treatment. That's the one thing that's just missing from the risk stratification data, isn't it? Cardiac index, it's not there. So this lady went on to IV, lots of side effects, didn't do well. Compassionate imatinib, didn't do well, got listed for transplantation, went into Zenith, which was the high-risk sotatercept study, got put onto Zenith, got transplanted, died 24 hours later of fulminant liver failure. I loved this patient. I mean, not like I love my wife, but really, really fond of this patient, really connected with her, and it was so tragic, so tragic. So, because there's somebody who tried to do all the right things in life, and we couldn't help her. So, I've got a couple more slides after this, but I just wanted to summarize this section. So, treatment goals should be individualized and based on multidimensional information. I think that's the point I was trying to get across with the portopulmonary patient who was high risk but had good hemodynamics. You just need to individualize things. The risk stratification would be really helpful, but it's not the absolute truth. We should, however, always aim for a low-risk profile. But if you reach a low one-year risk mortality, it doesn't mean that you can stop there. You need to keep going with risk assessment. Hemodynamic parameters can be really important as well as cardiac imaging parameters. And actually, maybe normalizing hemodynamics is what we should be aiming for potentially. After all, pulmonary hypertension is exactly that, pulmonary hypertension. If you want to cure pulmonary hypertension, you have to normalize the pressures. Okay. So just to finish off, risk stratification, should it be something that we use for enriching clinical trials? And so of course, all of our clinical trials are enriched, if you think about it, because you have to have, there's a maximum 6-minute walk that you're allowed to go into a trial. It's not a PA pressure of 20 and a PVR of 2 Wood units as entry criteria. It's often higher than that. So our trials are enriched, but maybe we need to enrich even more. So the PROSERA trial, which is the phase 3 trial of inhaled seralutinib, is looking at patients with a REVEAL score of 5 or more. And what this shows you is a whole sort of combined analysis of about 6,000 patients looking at REVEAL risk score and looking at the change in 6-minute walk on therapy in green and placebo in red. And you can see how the treatment difference in terms of 6-minute walk increases with higher risk patients. So that's, just to note. And then if you look in another way, low, intermediate, and high risk, you look at the delta 6-minute walk, you can see how there's a magnified effect in the higher risk patients. So you start lower, you achieve more. And so the phase 2 TORREY study, which is inhaled seralutinib, hit the primary endpoint with a PVR reduction of 14%, but the functional class 3 and the REVEAL 6 or more had a greater reduction in PVR, greater increase in 6-minute walk, and a greater reduction in NT-proBNP. So that's what's informed the phase 3 study. So I just wanted to put that in because that was the final little bit of the topic I had to cover according to my mandate. And there we are, we've got 3 minutes for any discussion. Thank you very much.
Thank you, Prof. Howard. Excellent talk and excellent case scenarios. We have learned a lot. Now the floor is open for questions.
I have so many questions.
Okay.
So many. Can we go back to the first case?
Oh, first case, yeah.
Yeah.
I'm not sure I can reverse all the way back.
Could we reverse?
There's 90 slides.
Because,
Maybe could you take me back to the beginning and then I'll forward.
So in the first case, everything was very good, but the patient kept having NYHA class 3 symptoms.
Yeah. Oh, yeah, stop there. That's great, thanks.
Yeah. Where is it?
I'll go forward now, yeah. I'll get the final when it was
Yes.
there.
This is the first case. So everything looked good, but the patient still had NYHA class 3 symptoms, and probably we should look for other causes, but we should still always trust the patient. I'm not sure what to do for such patients. Their cardiac index is 4. Maybe their cardiac index is 4, but the patient's heart rate 120, 130. That would put him in a stroke volume index in a lower stroke volume index, to be honest, because he's trying to compensate. This is number one. And number two, what is the role of exercise right heart cath in those patients? Because NYHA3, he's basically symptomatic only when he's moving. So is there any role? And if there is if this patient would have a very deficient right heart cath with exercise, is there any role to add anything else for such patients? And do we know if there is anything else that we can do for such patient? Because I'm wondering, someone with a good cardiac index, with a good PA-SAT or SVO2, and normal RV filling pressures, why would he still complain of NYHA3 if there is no other alternative diagnosis?
So he looked like somebody with scleroderma, but his serology was all negative. Mm-hmm. So I think there's possibly some other musculoskeletal issues going on. The other thing is that this guy always wants more drug. He wants more and more and more drug. But he thinks that, potentially he's being shortchanged if he doesn't get maximum drug therapy. So he always tells you he's breathless.
Maybe CPET would be a good,
So we
objective.
do, I didn't show the CPET on here, on this one, but going further back, you could see CPETs. And he also had quite a high VE-VCO2 slope with his low gas transfer. So I think he had a gas exchange problem that was giving him more breathlessness, which is a problem I find difficult to solve because you can treat the hemodynamics, but often these patients end up with a bad gas exchange problem. A bit like the 60-year-old man that I presented, really hypoxemic, really breathless with an MPAP of 22. And I think this is a cohort of patients that we see with low TLCO who are very symptomatic. They're probably, some of them are smokers. Some of them may have a KDR mutation. Yes. I see Stefan nodding his head there, yeah. And I think these people are symptomatic for non-pH reasons. So what I would do is I'd look at the CPET, and I would look at the exercise test, and I would see, does the cardiac profile look like during exercise they're uncoupling their right ventricle? Is the oxygen pulse falling off? The kinetics slow? Is the VO2 work rate slow? So I would look at that. And if I had suspicion from that, then I would do an exercise catheter.
Yes.
And then I might think about escalating therapy.
Yes.
Tricky cases.
Yes, they're tricky. And there's one more thing. If there's another patient that, I don't know, there was no congenital heart disease, but the patient the SVO2 was high, but she was still symptomatic. Did we look for other, extra cardiac shunting in those patients? Because
which patient was that?
I don't know which.
You presented so many.
You had a lot of cases. I should have written it down. I'm so sorry.
So yeah, I mean, we would always look for shunting with an MR, but peripheral shunting, it's quite hard to know how to look for that. Unless there's some kind of other sort of phenotype like telangiectasia or something along those lines. Certainly, liver disease will give you that high flow, yes. And I think that might be the case you were talking about, possibly. Yeah. Mm-hmm. So the portopulmonaries often get high flow.
Okay, we can have a question there. Yeah.
Look, thank you very much for this great presentation, as usual. So I have a question about the atrial septal defect with pulmonary hypertension, the young lady. Knowing retrospectively that she got worse, when we give the vasodilator therapy, there's going to be more shunting, right? We expect it is going to happen.
You're talking about the penultimate case with the ASD?
Yes.
Yeah.
So retrospectively, would you have closed the shunt early on? We have many patients because we will cause more shunting when you lower the vascular resistance, right?
So exactly, when we saw that 2.5 to 1 shunt, exactly at that point you should be thinking, should we? But that was when a hemoglobin had halved. We replaced the iron and then reassessed, and we did then refer her to a congenital unit where they did a hybrid cardiac MR catheter with the very question of should you close it, should you make it smaller? My feeling was probably you're not going to be able to, but I wanted somebody who closed shunts to tell me that.
No, I mean, when they get too far out, QP, QS, you should not close it. But early on, because we have so many of these patients, I don't know if anybody published on these cases where it is better to close it before we lower the pressure, so to prevent more shunting later on, a year, 2 years later. Is there any
So you mean close the shunt before you treat?
Or around the same time, because you're going to lower the pressure in the lung, you're going to cause more shunting left to right, right?
Yeah, yeah.
So over a year or two, this problem is going to exacerbate itself by creating more shunting.
I know, and I feel that she's on that borderline where, I mean, we're not going to close it, but you might make it smaller. She's on that borderline. I do agree with you, which is why I referred her, and they said no. But we do often get these patients and take an aggressive treat and repair approach. So many patients like this, we treat. If the PVR comes down sufficiently, then we might do a fenestrated closure.
Right.
So in this case, she didn't quite make it, but in many cases, we do exactly what you say.
So, I mean, there is data on this? Because the number of patients...
There are series of data, yeah, but I don't think it's anything more than experience of various centers. But the treat and repair approach is out there, yeah.
I see. Okay.
Definitely.
Well,
You don't want to miss the opportunity, do you?
Yeah. So is it standard of care to close it early on before there be more shunting, or just watch?
Yeah, so we would usually treat aggressively and then repair if the PVR comes down low enough, yes.
Yeah, okay, thanks.
Well, thank you, everybody. It was a great session. We would like to conclude now because of the time, and we will see you in the opening ceremony. Thanks a lot, Prof.
Pleasure.
Hello, test, check, hello, test, hello, check, hello, test. Check, hello.
check, check, law. Hello, test, 1, 2, law. Check, check, law. Test 1, 2, law. Check, 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 law. Test, check, 1, 2, hello. Hello, test, 1, 2. Check, law, test. Check, check, law, test 1, 2, check, check, 1, 2, law, test 1, 2. Check, law, test 1, 2, law.
test. Check, hello. Check, 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 check. Test, 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 test. Test, 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 test. Test, 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 test. I already informed doctor. Test, 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 test. Check, 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 check. Test, test. Check, 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 check. Test, test, test. Oh, fire no volume. Check, hello, test. Test. Check. Check. Test. Test. Check. Hello. Test. Check. Hello. Test. Test 1, 2. Check. Hello. Test. Test. Check. Hello. Test. Test. Hello. Hello. Test. Check. 1, 2. Test. Test. Test.
السلام عليكم، تسمعيني يا دكتورة؟
ايوه اسمع.
Welcome everybody. السلام عليكم. Good evening. It's nice to have you all here in the Gilead Survivor Pathway to Survival with sacituzumab govitecan GCC tour. And I would like really to thank Gilead to gather this very eminent speakers from King Faisal with Jeddah and Riyadh, and our international speaker from Florida. So just a few introductory slides, overview of triple negative and hormone receptor positive HER2 negative metastatic breast cancer. So we can move to the next slide.
Okay. Could you please be seated so we can start the program? All right. Well, assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, and welcome to the 18th annual meeting of SAPH. As you all know, SAPH has been organizing these, we call it now International Pulmonary Hypertension Meeting over the last 17 years, and every year the conference is getting bigger and bigger. And the relationship with our international colleagues and regional colleagues has also been expanding. This year we are expecting much more attendance physically and online. I was told by Hassan 2 weeks ago, actually, the online registration already passed 3,000. So I think, with the activity of SAPH over the last many years, the interest in pulmonary hypertension has been growing dramatically. The scientific committee of SAPH 18th has come up with a very comprehensive program. And as it is usual, the custom, we normally start the first night with only 2 talks, normally a keynote speech, and a clinical year review. And over the coming 1.5 days, they will be covering most aspects of pulmonary hypertension. Some of the sessions will be centered somehow around the outcome of the 7th World Symposium on Pulmonary Hypertension, but also we will be having this year a little bit more focus on the basic science on the pulmonary vascular diseases. The program normally ends on Saturday midday, but I truly encourage our colleagues who are physically attending to come up with questions between the sessions, at the end of the sessions, and it's a really good chance for you to interact with your colleagues from here, from outside. We have a good number also this year from international experts in pulmonary hypertension, and this is your chance to learn something from them. Tonight, obviously, the dinner will be here. This is some housekeeping notes. And tomorrow we'll have a gala dinner in a much better place. And this year we have guests from Asian countries, and from Australia as well. Our colleagues from these countries who happen to be the head of societies as well, they will greet you after the end of the session from Australia, from Japan, and from China. Our colleague from Taiwan will be arriving late, so he did not have a chance to greet you as well. The first session normally covered, I'm chaired by 2 chairmen. My pleasure to co-chair this session with Dr. Saleh Al-Dammas, who is a senior colleague of ours from Military Hospital, who is a pulmonologist, also interested in pulmonary hypertension. And in fact, he was one of the few people who participated in the foundation of SAPH. So with that, I will leave you with the first speaker, will be introduced by Dr. Dammas, and thank you all for attending.
Thank you very much, Abdullah, and looking forward to a very successful meeting as usual. And it's with great pleasure that I invite the first speaker, Professor Gala, who is coming from Bologna. And I don't have to introduce him because, as you know, he's a world figure in the field of pulmonary hypertension. And over the next few minutes, he'll be talking to us about the milestone, the journey of development of the 4 pathways in the treatment of pulmonary hypertension. Professor.
Thank you for your kind invitation and presentation, and for this lecture, which is related to the development and improvements of the knowledge on pulmonary hypertension. We started the journey in 1961 when a report of WHO expert committee on chronic cardiopulmonary clearly specified that the mean PAP does not normally exceed 15 millimeters of mercury at rest, and that this value was little affected by age and never exceeded 20. So we started where we are now. Then there was an opportunity to another meeting at the WHO in Geneva in 1973 due to the epidemic of aminorex, which is an anorexigen drug who induce pulmonary hypertension. At that time, the mean pulmonary arterial pressure to define pulmonary hypertension was increased to 25 to try to avoid people with parenchymal lung disease, which may have a minimal increase of mean pulmonary arterial pressure. In Geneva, still there was a very small classification, for example, primary versus secondary, and 3 pathological types, and was started the famous NIH registry. And this is the clinical classification which was adopted from 1950 to 1998, primary, pulmonary hypertension, secondary, and associated. Then Evian, 1998, again another epidemic of pulmonary hypertension due this time to another anorexigen drug, which was the fenfluramine. The 5-class clinical classification on pulmonary hypertension was launched in Evian, as well as the concept of pulmonary arterial hypertension as a group of disease. Some additional knowledge on pathobiology was diffused, and also the first drug approved for PAH, epoprostenol, was discussed at that time. This is the famous Evian classification, and every 5 years is adjusted a little bit, but the structure is in place since 22 years without major changes. And then we arrived to Venice in 2003, the third World Symposium on Pulmonary Hypertension. At this symposium, we changed the definition of primary pulmonary hypertension in idiopathic pulmonary arterial hypertension. We started to talk about genetics, and it was proposed a diagnostic algorithm. It was discussed the vasoreactivity, and also the first treatment algorithm with 3 classes of drugs was proposed. So already in 2003, we had 3 classes of drugs, and we also proposed treatment algorithm. On the left, on the left, you see the first treatment algorithm with only 2 drugs, calcium channel blockers and epoprostenol. Then, time by time, the complexity of the treatment algorithm increased. And we arrived in 2008 in Dana Point, US, and in this World Symposium, the wording heritable pH was proposed. The description of PVOD also was improved. And for clinical trials, it was proposed to utilize not anymore 6-minute walking test, but the time combination therapy, and also some definitions of post-capillary pulmonary hypertension, isolated or combined. NICE 2018, for the first time, a task force of patients was invited. And there was an extension of the knowledge of genomics. And at that time, we went back in the definition of pulmonary hypertension, mean PAP, more than 20 millimeters of mercury. New treatment pathways were proposed, and again, initial and sequential combination therapy were occupying the large rooms in the treatment algorithm. And then we have the 7th World meeting that was performed in July last year. And in this case, I try to give you more information about the key findings of the 7th of VSPH. The concept of pulmonary vascular remodeling as an hallmark shared by all forms of pulmonary hypertension is a concept that was reported, and all these pathological changes were identified in the distal part of the pulmonary circulation. And then again, expansion in the knowledge of genomics with the identification of rare variants in several novel genes, as well as common variants that confer a modest increase in pulmonary arterial hypertension risk. And this is the omics. There has been an expansion of this basic area, so not only genomics, but epigenomics, transcriptomics, translatomics, and proteomics, and so on. So there was an extension and diffusion of studies about pathobiology. And this is also an expansion of the knowledge in genetics. You find here ligands, receptors, signal transduction, and gene regulation. And is expected in future a further expansion. What about pathophysiology of the right ventricle? Pathophysiology of the right ventricle is described by the afterload mismatch, with one characteristic of the right ventricle. And it was demonstrated that the right ventricle can recover to a great extent in the loading conditions of the right ventricle. And if the afterload is reduced by 40–50%. It's not easy, but in some cases this can be demonstrated, for example, after double lung transplantation. Again, the evolution toward heart failure is not related only to the afterload mismatch, but also to the right ventricle cellular and molecular changes. Innovative imaging also in the 7th World Meeting were discussed, and also the concept of risk stratification. So this is new and modern imaging of the stress assessment of the right ventricle, and also nuclear magnetic resonance imaging depicting not only the flow but also measurement of the cardiac output. Finally, we go to therapy. Of course, therapy is very relevant. However, we have to recognize that the PAH patients may deteriorate also despite maximal pharmacotherapies. And we should not forget lung transplantation, which remains the only resource for a consistent group of patients. A new treatment algorithm was proposed, and three pathways, the first three pathways which were utilized since you have seen 2003 concern endothelin pathway, nitric oxide pathway, and prostacyclin pathway. Interestingly enough, these three pathways were studied first in the humans and then confirmed with animals. In fact, you see here three articles related to epoprostenol in 1984 in a young lady which improved dramatically after epoprostenol, and bosentan in 2000, and sildenafil in 2000. So it's a sort of reverse remodeling of the knowledge in areas. First animals and then humans. In this case, it's the opposite. And these are the studies. Maybe someone is missing, but they are 46 in the range of 20 years with different type of programs and endpoints. And this is the last treatment algorithm, and we don't go into details, but just to show you that in the boxes related to intermediate, low or high risk, and also in the box of high risk, there are a lot of or. Or means that we have no evidence-based knowledge to decide which one. And we will see in the future if we will be able to get more knowledge to avoid or, but to give a sequence of treatment possibilities. And this is a picture which show the fourth pathophysiological pathways, again, which is the activin signaling inhibitors, like sotatercept. And we will see also in the future how to combine the three pathways in different patients and also in different combination. Are these drugs disease modifiers? This is an important question But the answer is based on randomized control studies again. Randomized control studies are the most important. In particular, studies which also are blinded. How we can define the effect of drugs disease modifying? We have to randomize the patients treated with favorable effect and then randomize them to the withdrawal of the drug or the continuation of the drug. If after the withdrawal the favorable effect is persisting, this is disease modifying. Otherwise, all concepts based on biology are less relevant. So the last two types of pulmonary hypertension are the class 2 and 3, so due to left heart disease and lung disease, and there is an inverse proportion between the size of the patients and the knowledge. In fact, the gaps of evidence in pulmonary hypertension due to left heart disease or lung disease are very large, and we need to get an important improvement in this area. And finally, an area in which there has been an enormous progress, and this the treatment of chronic thromboembolic pulmonary hypertension based now on three possibilities: endarterectomy, balloon pulmonary angioplasty, and targeted medical therapy. So this is the history of the World's meeting, and this is a new strategy that the scientific committee of the World Symposium on Pulmonary Hypertension Association to implement also meetings in between the 5 years who separate the traditional world meetings in order to have more time to discuss hot topics, in this case from the 8th World Symposium, which will be in 2029 in July, while this update will be in Bologna on July 3rd to 5th this year. Thank you.
Thank you very much. Professor, can you join us here, please? Dr. Gala? Yeah, please join us here. So we'll have questions at the end of the session. Let Dr. Abdullah introduce the second speaker, and we'll leave questions after the second presentation.
Well, it's my pleasure now to introduce our new friend, Professor Thomas Pulido from Mexico. He's going to talk about year in review. So, Pulido, is your podium is yours.
Thank you. Thank you very much. Thank you, Abdullah. Thank you for the invitation, if you have the pointer. So I have the not easy task to talk about the year in review. And if I can get my first slide, it's going to be the year in review after Barcelona. Why? Because after Barcelona, because you're going to hear about the 7th World Symposium through these 2 days. So I'll try to get to my best. And in the end, it's my opinion. So these are my conflict of interests. And this is the agenda. We're going to talk a little bit about personalized medicine and deep phenotyping, global epidemiology and burden of PAH, advances in risk variables, and novel therapies. So I'm not an expert in deep phenotyping or in omics, but let me show you a couple of studies that really really surprised me because of the methodology that they chose. So this is a collaboration between Denver and Stanford, and the objective was to characterize circulating peptides, metabolites, and lipids, and they analyzed with mass spectrometry and advanced computational tools 402 PH patients and compared them with 76 healthy subjects. So basically what they did is they took blood samples from biobanks, and then they put mass spectrometry, they analyzed the molecules, and then they applied deep machine learning. And what they found was 832 peptides from 291 proteins, 45 metabolites, and 222 lipids related to pulmonary arterial hypertension. Of course, in all these analyses, they do some crosstalk, they do some t-test to compare with controls and with the variables. And in the end, they took out the molecules that we already knew that were participating in pulmonary arterial hypertension. For example, interleukins, for example, resistin, for example, activin. So these are, on your left side, the characteristics of the subjects. 402 PAH subjects. The mean age was 52 years old, and most of the patients were from the United States. And what is important is, in the right you can see this volcano plot, and the x-axis you can see the change of the magnitude of the change in the molecules compared controls to PAH, and in the y-axis you can see the significance. It's the logarithm of the p-value. So the higher the molecule, the more significant. The left panel is the less change, and the right panel in red is the higher change. So you can see that the one that strikes out is 2-hydroxyglutarate. So what they did is to deep studied this 2-hydroxyglutarate with machine learning, and what the authors found is that 2-hydroxyglutarate was elevated in patients with PAH as compared with controls, but in the middle panel you can see that this was the same across different types of pulmonary hypertension. For example, congenital heart disease, connective tissue disease, CTEPH, IPAH, and portopulmonary hypertension. And what is more important is when they analyze the variables and the treatment that these patients were subject to, the treatment with 2 and with 3 drugs decrease the values of the 2-hydroxyglutarate. I forgot to mention that this 2-hydroxyglutarate is a metabolite of hypoxia signaling pulmonary hypertension, and it's based on smooth muscle cells and peripheral blood. And also, what they showed is that the higher the 2-hydroxyglutarate, the lower the survival. So I think this is an important study. And finally, what they concluded is that 2-hydroxyglutarate emerged as a significant biomarker in the study for distinguished PAH and healthy subjects, and levels were consistently elevated across all types of pulmonary hypertension, and it was associated with poor outcomes. Now, the second study is a study made on lung tissue from PAH patients and from controls. And this is an integrative multiomics in the lung, and what they did were they took the lung samples, analyzed the genome, and what they found were clusters of different genes and some clusters of the same genes that we knew about in pulmonary hypertension. So if you can see in the right top panel, there were like two clusters, the one in pink and in blue, and these clusters were two separate genes that were not described in pulmonary hypertension. So this gene was the ASPN gene that codifies for aspirin. And aspirin is a protein that has a lot to do with metabolism, and it all depends on the type of cell that has the receptor, the effect of the aspirin. For example, if you analyze the aspirin in breast cancer, aspirin has a protective effect in breast cancer. But if you analyze aspirin in colon cancer, it has a deleterious effect in colon cancer. So the important thing, or the interesting thing, at least for me, is that this gene and the aspirin correlate very well with the severity of pulmonary hypertension. So again, what they did is a little bit what Nas mentioned before, and what they did is they took the gene, they analyzed the gene, they knew that the gene was upregulated and in pulmonary arterial hypertension. So what they did was just to build a mice model of pulmonary hypertension with a knockout gene of aspirin. And what you can see in the top panel is the control rats or mice, and the surgeon model of pulmonary hypertension, and then on the far right, the model without the aspirin gene, and you can see there's also an increase in the medial or in the thickening of the artery. And then what they did is just to build recombinant aspirin, and when they included the recombinant aspirin, the recombinant aspirin decreased the thickening of the pulmonary artery in these mice. So again, this is a work done first in humans and then translate that work into animals. And basically, the idea is that aspirin is upregulated in lungs and plasma in different PAH cohorts. They correlate with the hemodynamic values. If you have decreased aspirin, then you have an increase in vascular remodeling, and if you have increased aspirin, you have a better remodeling of these vessels. So this could be a choice for more studies and for a novel therapeutic strategy. So worth mention, there were also a couple of studies talking about vitamin D and the vitamin D receptor. And you know that vitamin D and the receptor has an important metabolic effect in pulmonary arterial hypertension. And if you give calcitriol to enhance the vitamin D metabolism, you could decrease pulmonary hypertension. And then the other study that is worth mentioning is the aberrant long chain fatty acid metabolism, and we're hearing about more fatty acids in systemic sclerosis. So what about the global epidemiology and burden of pulmonary hypertension? This is a survey that was conducted in physicians and their patients. So basically, it was a cross-sectional survey released by physicians in the US, the European Union, France, Italy, Germany, Spain, UK, and Japan between March and August of 2022. Data was collected for 1,100 patients and almost 300 physicians. The mean age of the patients was 58 years old, and 54.6 were female. Now, important thing is 91.2% of the patients were receiving or had received specific PH treatment, but the interesting result is this. Overall combination therapy was 53%. The number of combination therapies was lowest in the US and was highest in Germany, but Germany had 35.6%. So again, we are not following the guidelines. And what are the factors associated with a shorter time to the start of combination therapy? Higher risk status, which is logical. I mean, the sicker the patient, the more aggressive we have to do. Care by a pulmonologist. So this survey was made with cardiologists, pulmonologists, internists, and rheumatologists. And apparently, us pulmonologists can prescribe combination therapy early. And of course, we need more comprehensive assessments. And hospitalization in the past 12 months also was a factor to start combination therapy. We kind of did the same in Latin America, in 4 countries, Colombia, Brazil, Mexico, and Argentina. And as you can see, I mean, we always blame our monotherapy because of the lack of availability of the new drugs. But if you think, compared to Europe, we're not that bad. And the thing is that in Mexico, we have free prescription of these drugs. It's a little bit more like the United States, so everyone can prescribe the drugs. So if you look at the left panel, you can see in the first column that 51% of all patients, 958 patients, were on combination therapy in non-PH centers. But if you go to university centers or PH centers, then the combination therapy was really high. And this is important because nowadays in Latin America, we're trying to get networks, reference networks, kind of the same as France, for example, that could homologize the treatment of these patients. What about the advances in risk variables? Well, something that everybody was, well, at least in the PH community world, was expecting was the PEXNet clinical trial. This was mentioned by Gabor Kovacs in Barcelona, but the paper was published after Barcelona, and this is the result of the multi-center study of exercise pulmonary hypertension. So in the left, you can see 764 patients were evaluated, 64 female, 36% males, and the average age was 59 years old. Most patients were on functional class 2 and 3. I mean, functional class 2 were 53%. And you can see the main hemodynamic data on your right. So what is important with this study is that for the first time in a retrospective analysis of more than 700 patients, we found out what we were defining as exercise pulmonary hypertension. So you have 3 models, Model A, Model B, and Model C. Model A is each variable analyzed separately, adjusted by sex, hemoglobin, and for age. And you can see that in the Model B, there's a multivariate analysis, and Model C is multivariate analysis and significant resting values. So in the multivariate analysis, there was a significance in the transpulmonary gradient and in the cardiac output. So the higher the cardiac output, the better the response, and the lower, the higher the transpulmonary gradient, the poor prognosis. And if we analyze the hemodynamic responses to exercise, the rest to peak difference, then we can see that again the mPAP-CO slope was really significant. So again, in the left, you have the survival of these patients, and you can see for the first time what we were saying about exercise definition of pulmonary hypertension. Those patients that had a slope, mPAP and to cardiac output slope less than 3 millimeters of mercury per minute per liter had a better prognosis that in survival than those patients that changed the slope more than 3. And interestingly also, when they analyzed the pulmonary vascular resistance, what they found is that the higher the PVR, which is the bottom line, the worst survival. But if you look at the best survival, which is the green line, the important thing is it's not the patients with the lowest PVR, which is 0.9, but the patients that have between 0.9 and 1.3 slope with units, sorry. So this could be in part due to the tone, to the vascular tone, of the systemic circulation and of the pulmonary circulation. So the conclusions of this study is this is the largest multi-center database on pulmonary hemodynamics during exercise. It was a retrospective analysis, and also one of the limitations is that the exercise protocols were really different from center to center. However, all were done on cycloergometer, and nowadays there's a prospective study going on, and the aim is to recruit 500 patients. Another interesting study is the positive vascular reactivity testing in the modern era. This was a study basically performed in Germany, Switzerland, and Austria. And what they do was, out of 3,000 patients with right heart cath, and in almost 2,000 patients where the acute vascular responder test was performed, they analyzed the long-term survival. So the response criteria was the same as we usually do, as Olivier's paper, greater than 10 millimeters of mercury of decrease in pulmonary pressure, an absolute value of 40 millimeters of mercury without any change or an decrease or with an increase in cardiac output. So what you can see there is, again, 10% of the patients responded. This is all things. These are things that we already knew. Of these 10% of the patients, it is interesting that 22 patients, which is the white square, did not receive calcium channel blockers, even though they completed responder criteria. And the reasons were really because intolerant of calcium channel blockers, because the patient didn't want to use a calcium channel blocker, or because the patient had to be included in a clinical trial. So again, the final analysis was done on 123 patients on monotherapy and 39 patients that, besides being initially responders, they had the physicians added PAH-targeted therapy. This is the evolution of the patients. This is on your left you can see the whole group, and on the right you can see, let's say, the long-term responders. And what you can see is that with the whole group, you can see in yellow patients that still died on calcium channel blockers and some other therapies. But for those patients that had a really long response, the deaths were really small. Patients were still, a greater proportion of patients remain on monotherapy and also on combined therapy. And what's important for this paper is that the association with long-term response was due to an early evaluation of functional class, risk status, 6-minute walk distance, and NT-proBNP. So what I mean with this is that if I have a patient that responds to an acute vasodilator test at 3 months, if the NT-proBNP is low, if the 6-minute walk distance, if they walk farther, and they still are in low risk, their response is going to be really good at long term. And you can see also they analyze pulmonary artery compliance And what they found is that pulmonary artery compliance of less than 2.5, even though those patients were responders, that compliance was associated with poor prognosis. So again, this subset of patients, less patients, failed to show a sustained satisfactory response, and this was related to a PA compliance of less than 2.5, no low-risk status, and elevated NT-proBNP. So this is like an update of the responders. Worth mention, a work from the French group, from Olivier, and worth mention because I think it's interesting, because what they did was exercise test in asymptomatic patients with BMPR mutations. And what they found is that in 3 patients that developed pulmonary arterial hypertension at follow-up, the pulmonary vascular distensibility was markedly reduced in patients with, that were asymptomatic carriers. So I think this is also an important thing, and this could be like a point to do more studies. And the other worth mention study is Athenaeus' publication, and it's worth mention. I'm not going to say anything because yesterday Athenaeus is going to be, it's going to expand on this risk stratification. But what is important is just to mention that the problem that we have with the intermediate risk is that patients in intermediate low, they're really not in intermediate low. In intermediate high, there might be in high risk, and even patients with low risk might be in terms of heart function, not on low risk. So if we add hemodynamics to this stratification, then we can do better with the drugs. Novel therapies, just to, in the next couple of minutes, we have a couple of publications. The first one is ADIEU. The first study, randomized trial of a single dose, single pill combination of macitentan and tadalafil, 10 milligrams of macitentan with 20 and 40 milligrams of tadalafil, compared to a single dose, to a single therapy of macitentan and tadalafil. The primary endpoint was PVR, and as you can see in your the right panel, the single fixed dose decreased the PVR in 45% as compared with macitentan, 23%, and 44% as compared to tadalafil, 22%. So yes, there were a little bit more side effects with the combination, but the combination, the startup combination was effective. Another study, the Insignia PAH trial, MK5475, or how I call it, inhale Riociguat, which is basically the same, is an SGC stimulator. And this was a phase 2 study that evaluated the changes in pulmonary vascular resistance, 3 doses of this drug, 32 micrograms once a day, 100 micrograms once a day, and 380 once a day, inhaled. And the difference of the inhalation is that the device was fixed, and the device had a counter that it was decreasing, more like some bronchodilators that we have used. So in the end, the study was positive. PVR decreased with the intermediate and higher dose. But the thing here is that all secondary endpoints, meaning the rest of the hemodynamics, 6-minute walk distance, NT-proBNP did not change. So even though this was a positive study because of the primary endpoint was met, the secondary endpoints were not met, and the sponsor decided to stop the program in pulmonary arterial hypertension and then moving on to some other diseases, for example, PH-COPD. And finally, the seralutinib study, we have, we've heard some of the results this morning. Seralutinib, it was a phase 2 study that included 42 patients in the placebo arm, 44 patients in the seralutinib arm. Primary endpoint was the decrease in PVR, and in the right you can see the demographics. Probably what is something that we have to point out is the years since pulmonary arterial hypertension diagnosis. In the seralutinib arm, 4.8 years, and in the placebo arm, 7.3. So that means that in the seralutinib arm, patients were less prevalent than in the placebo arm, but in the rest of the variables, they were pretty much homogenized. You can see, for example, that 6-minute walk distance patients were walking more than 400 meters. And these are the main studies. The TORREY study was positive. There was a decrease in pulmonary vascular resistance, and it was positive. But if there was a sub-analysis that was pre-specified of patients in functional class 2 and functional class 3, and what you can see is that the magnitude of decrease in pulmonary vascular resistance was greater in patients, in sicker patients, patients in functional class 3, and also in terms of the REVEAL 2.0 score. Those patients that had a higher score, more than 6, had a better response. So there was no changes in the rest of the hemodynamics. Surprisingly, there was no change in cardiac output, and we can discuss this later. So in the end, seralutinib is a new potent drug, a PDGFR, CSF1 receptor, and c-KIT kinase inhibitor that significantly decreased the PVR, and we are following the phase 3 study that is ongoing right now. I have to mention a couple of studies, negative studies. Rodatristat, the one that has to do with serotonin metabolism, was negative, and was not only negative, but patients that received the drug worsened their PVR and their hemodynamics. There was also the PHANTOM study with anastrozole, which is an estrogen blocker, that was not significant. And then a couple of studies with inhaled imatinib and cibotercept, which I think they're not published yet. So, in conclusion, 2024 marked a significant progress in understanding and treating PAH. We are approaching, as Nas mentioned, the omics era and the deep phenotyping, and we're getting close to find out which drug will serve or will be more effective for each patient. Global epidemiology continues to change, but still we don't follow the guidelines. The combination therapy in all parts of the world is really low, and for now we now have to include new risk stratification parameters, for example, exercise and hemodynamics, and focus on novel therapies, probably the fifth pathway that is coming. And with that, I thank you very much.
Gracias, Thomas.
Yeah, thank you.
Come here, please. Join us. I think we have 10 minutes for questions. Anybody has any comment or question? I might start. So, Thomas, for those patients who are now, we know of the slope of mean pulmonary artery pressure or cardiac output more than 3, they do worse, but we don't have also recommendation to treat them. So what would you do for these patients?
Well, I think the first, one of the things that I didn't mention is one of the inclusion criteria of the study were patients with less than 25 millimeters of mercury of mean PAP, and the average mean PAP was 17. So we're really finding a group of patients that increase or develop pulmonary hypertension and exercise. And I think we have to follow those patients. We need trials, and the prospective study will give us some information. But if I have to answer concretely, is probably in the subset of scleroderma or connective tissue disease, if we find a patient that has these parameters, it would be worth treating them, especially, of course, if they have more than 20 milligrams.
Well, with
millimeters of mercury.
target therapy, like monotherapy, right?
Yeah.
Yes.
Yeah, because we don't have information
Yeah.
so far.
Any questions? For those patients who have been diagnosed with being vasoreactive, and in the first visit they have those 3 bad risk factors. Compliance isn't the best, pro-BNP is borderline, and functional capacity maybe. So that is the first visit. Both of you, the question for both of you. Would you wait until you up-titrate the calcium channel blockers to the max, or you actually add a target therapy while you are up-titrating them, the calcium channel blocker? I don't know, maybe there is no clear answer for this, but maybe a practical question and answer.
Okay, so the thing is that what we were doing with those classic responders is repeating the right heart cath after 1 year, okay? But the thing is that we have to follow them because they may deteriorate, and we have to use the strategy that comes in the guidelines every 3 to 6 months. Now, we are using high dose of calcium channel blockers, so if I find a patient that is deteriorating, I will add a new strategy or a new drug, probably monotherapy or combination.
In my center, even if we have no data to support this behavior, but we try to maximize the dose tolerated, also utilizing for 2 to 3 times also an additional nitric oxide test on top of a calcium channel blocker to see if there is residual vasoreactivity to recruit in order to give the maximal possibility of the effect of the... But again, this is what we do, but no, we don't have any data supporting this.
Usually when we repeat the right heart cath, we again test them, as Nas mentioned. So we have found patients that do not respond in the same proportion, so we'll look after them.
Any further questions? Use the mic, please.
Sorry, just in those who, after being responders for vasoreactivity and calcium channel blockers, if with time the vasoreactivity gets reduced or they stop responding, do you withdraw the calcium channel blockers or continue, but maybe with a smaller dose?
What we do at our center is we continue the calcium channel blocker if tolerated, and we add some other drugs if they are not responding the same. We usually, we use, right now we are using amlodipine, probably 10 to 20 milligrams if tolerated. But in the end, if the response is not the same, then we add drugs.
Noel?
Can you hear me?
Yeah.
Okay. So thank you for your talks. Doctor, you mentioned about a study of inhaled soluble guanylyl cyclase stimulator. Were the patients treatment naive, or were they were already on treatment? And did they stop the riociguat or the sildenafil they were on? Did they stop that arm? And did they have more hypotension or side effects from that side? And how did we know this study was positive if it was stopped by the sponsoring company? Thank you.
Okay, so the study was not stopped by the sponsor. There was a 12-week, an interim analysis between the 12 weeks, and the 12 weeks was the final analysis, and some patients were moved to the to the open label. The only contraindication was riociguat, but patients were allowed to use PD-5 inhibitors. So they were not naive patients, they were patients on mono, on double, and double therapy mainly, not really triple therapy. And after the 12 weeks, when the final analysis came, the primary endpoint was met. So it was a decrease in PVR. So that's why I mentioned it was a positive study, but all the secondary endpoints were negative. I mean, there was no difference in 6-minute walk distance, cardiac output, mean pulmonary artery pressure, 6-minute walk distance, and so on. So it was decided by the sponsor to stop not the development of the drug, but the program in PAH. So it is my understanding that now they are kind of, I don't know if the study is already ongoing, but it's COPD, a PH COPD. So that's where they are moving to, but they stopped the drug for PAH.
Any further questions? No? Well, you have any? No? Okay. Well, thank you so much. It was a very fruitful session. Thank you for your both speakers. And please stay. We will have our colleagues from Eastern societies greeting you and talking about briefly 2-3 minutes about the PH status in their countries. So we will start with Dr. Well, supposed to be Dr. Anna Jimenez presenting PVRI, but unfortunately she lost her mom recently, so she couldn't make it. So I think we'll start with John Finestra from Australia. He will be telling us in 2 to 3 minutes about Australia and New Zealand as well, and some PH status there.
So we...
Thank you. Yeah, I'm John Feenstra from Brisbane, Australia, and representing my colleagues and obviously patients as well from Australia and New Zealand, and I'm the current Pulmonary Hypertension Society of Australia's president. So I have to say my 24-hour, my last 24 hours here in Saudi Arabia have been an excellent time to meet colleagues, and I've met Professor Abdullah last year in Korea, and I'm very thankful for the invite. So, and Hassan has made us feel very welcome, myself and my study coordinator, and also the hospital visits, seeing how passionate they are for their treatment programs, their research, and their dedication to their patients. Again, I'd just like to thank you again for the hospitality, the kind invitation, and I'm really appreciating this opportunity to engage with discussions with my colleagues here, collaborations hopefully in the future, and shared goals for patients with pulmonary hypertension with our countries. So it takes us about 16 hours to get here. We're a big country. You can fit Europe twice into our land, and New Zealand's just south of us. We have cute, cuddly animals. We also have animals that try and kill you. New Zealand have some nice birds. When I was looking up animals of Australia, actually camels came up. We actually have the largest wild herd in the world at 1.5 million camels throughout Western Australia and Northern Territory. Hassan said I could plug my society's meeting. So we have an annual meeting every year. Sean Gain, and was 2 years ago. We had David Kiley last year. We have this year, it'll be in Brisbane again, my hometown. It's over 2 days. Again, very excellent science is discussed. We have a master class as well for colleagues that may not have that much experience in PH, and I think it's a very fabulous conference as well. And this year, we've got John Luke as our main international speaker to come out for 2 days.
We won't probably do as many talks as what we made Sean do. He did 6 talks for us for the time that he was there, but I'll negotiate that with John Luke. But thank you again for inviting me, and I look forward for the next couple of days and also speaking with you on when I speak on Saturday. Thank you again.
Thank you, John. Well, we have something in common between us and Australia, camels. Yeah, so thank you so much. So it's now a turn for Professor Zheng from Guangzhou, China. Please, Professor.
Thank you so much. Thank you very much for your invitation, for the invitation by Professor Abdullah Al-Dalan, right? And Professor Hassan Al-Rini. Thank you very much. This is the first time for me to visit the great city, great country, and this is, I believe, this is a great opportunity to give me a join your meeting and introduce me and my center and the East Asian Society of Pulmonary Hypertension. And we like very much to welcome all of our friends to visit us. Why? Because we, my personal opinion, we have the best restaurant in China. Maybe somebody don't agree with me, but I believe this is the best restaurant in China. You should try the best food in China. And the next. And after dinner, you can have a very nice Pearl river. This river very famous in China, Pearl River. You can have a very nice Pearl River night cruise and see the best view of central of Guangzhou. And the weather is very, very good. Professor, several years ago, me and the Professor Dui and the Professor Chang from Korea, Professor Dui from Japan, and some friends from China, Japan, Korea, founded the East Asian Society of Pulmonary Hypertension. We have the same, the very similar population, some special disease. For example, the Takayasu arteritis, and the connective tissue disease. So we always welcome all our friends in the pulmonary hypertension community from Europe. Olivier, there are some friends from Europe and from America. We work together to fight against the difficult disease. Thank you again for my friend, Professor Abdullah Al-Dalan and Professor Hassan Al-Rini. Thank you very much.
Thank you so much, Professor Zheng. So it's now the turn for Professor Fukumoto from Japan. At the end of the day, Saudis are also Asians. Remember, we are the west part of Asia. So we have something in common. We're living in the same continent.
Thank you very much. First of all, I congratulate for this wonderful Congress. And this is my great honor to be here. And thank you again for inviting me.
And I'm Yoshihiro Fukumoto, president of Japanese Pulmonary Circulation and Pulmonary Hypertension Society. And I'm a cardiologist, a professor and chairman in Crimea University. We have a Japanese Pulmonary Circulation and Pulmonary Hypertension Society, which merged from two different societies 10 years ago. And we have some missions expressed in our website. But I'm sorry, our website are written in Japanese. And my, one of my next missions as a president is to add an English version in a few months. And we have several missions for pulmonary hypertension medical development. And which one? We have also constructed a nationwide pulmonary hypertension registry from group 1 to 4. And our society has 700 members, and among them, 600 are medical doctors, cardiologists, pulmonologists, rheumatologists, hepatologists, and pediatric cardiologists and surgeons. And we have written several guidelines, but all of them are in Japanese, though. Some guidelines collaborated with the Japanese Circulation Society are written in English, which is published every 5 years. And thank you again for inviting me in Saudi Arabia. This is my first visit, actually, and very, very fantastic. Thank you very much.
Thank you so much. Professor Wang is supposed to be also here, but he just arrived to the airport, so he wasn't able to make it. Well, this is the custom for SAPH. Normally, we start with these two excellent talks, and then we have also some greetings from colleagues from everywhere in the world. We just started also this year having someone from Latin America, and maybe we'll have also future collaboration with other places in America and Latin America. Tomorrow, the program is very comprehensive, so I really highly recommend you all attending every single lecture of that program. You have pioneers of pulmonary hypertension experts are here, so this is a very golden chance for you to attend. So thank you so much for tonight, and then Hassan can let us know where the dinner is. Downstairs. So the dinner is actually downstairs on your left side. And thank you and have a good night.